So first question for today, who's gonna take it? Okay, Dr. Isabella, please. Dr. Isabel, please.
Okay. Good morning, doctor.
Good morning. So, gift question for you. Let me open the black box.
Oh no,
Yeah.
it sounds scary.
No, it's okay. So, any question, guys, we are doing, you need to go and search for it. Any ethical point, any point we are speaking about it, do not sleep this day till you search for it and look for it, make note out of it. So, okay, let me share it with you. Okay, this one is good.
Okay, should I read it?
Yes.
Which one of the following is the most appropriate next step? A 29-year-old woman presents to your clinic requesting help with housing. She recently left an abusive partner and has been staying intermittently with friends. She has no acute injuries and says she doesn't not want the police contacted. She asks whether there is any way you can help finding a safe place to stay and support for her and 4-year-old son, who is currently with her. Okay, first of all,
Easy.
no, it's not easy. It's never easy. But okay, let's break the question. So she's a 29-year-old woman. She has no house. Um, what they're saying is that she left an abusive partner. She has no injuries, so I think she's fine. But she doesn't want to contact the police. So the first thing that I will do with this patient is just to give a.
Mm.
She's asking for a safe place, right? That's what the question is about.
Mm-hmm.
She's asking for a safe place and support for her 4-year-old. Well, we can guide her to safety plan or provide her with a supportive care. Look for groups, supporting groups, maybe inside the community. Guide her to that place because she's not injured. So it's more
Mm-hmm.
like provide her with a safety plan for her and the kid or a safe place to go. She
Mm-hmm.
doesn't. We don't need to get the police involved here because she doesn't want to. But just let her know that she can always go to the police just in case she needs it. But I will guide her to more to the community, to the groups, to the shelters, to all the safe places that she can go.
Mm-hmm.
I
Do you
will
want me
do
to
that.
give you some options?
Yes, please. I don't know if that's
Okay.
easy, but yes.
Okay, let me give you some options.
Okay. Okay. Option A. Advise her to return home if she feels the violence is unlikely to recur. No, I will not choose A. B. Encourage her to contact the police before any other services are arranged. She can always contact the police, but it's not required for now. So I will not choose E. C. Refer her urgently to community resources for immediately partner violence. D. Arrange outpatient psychotherapy before addressing her housing situation. E. Contact Child Protect Services immediately because she is homeless.
All
I
what
don't
you are
know.
dreaming about. All what
I
others
already mentioned all of these. So,
all what others they are just writing and they are thinking about. What do you think, guys? What is the correct answer? Come on, guys, it's a warm-up
Excuse
question.
me, Dr. Abdullah.
Yes.
Good morning.
Good morning.
I just joined and I missed the question. If you could, if it's not too much, you could
Yes.
just rephrase the question so that we could be abreast of what is
Okay,
happening.
I'm gonna resend it again.
Dr. Abdallah, is it C correct?
I
Because we
need.
can refer urgently community resources.
Okay.
We shouldn't call CAST because she's with her child. She's protecting her child. So I think that for this, C could be an answer.
Okay.
The problem is option E, half of it is correct. Then whoever wrote the rest of option E made it worse. Like it started very good.
That's how it works when they
Then,
give you options.
No.
because it's homeless, it's nothing related to homeless here. So it's not
No,
E.
Dr. Andrew. In the question, they are telling you she's coming to request help with housing. This mean, or
Yeah,
they are giving you.
but the CAS, contacting CAS is a different story away from housing. This is away from social services. CAS is for imminent danger. If the child undergoing or there is a suspicion even of danger, this is CAS. Homeless and housing, that's, I don't know, that's a different story. So I don't think it's E.
Hi, doctor.
Right.
I think I will go with option C, refer her urgently to community resources for the partner balance. Usually they provide with housing and resources. So that's what she's coming for. Like,
I also go for C because shelter and crisis shelter, they comes under community resources. Yeah.
exactly. And they provide housing and
Yeah.
they can help her with that. Because like that kind
It's
of
not that
felt
urgent that we need to call
correct.
CAS or
It fell
police.
out of the scope of
How
the
about the
doctor.
police? All of you left the call the police.
But why would we call the police on her?
No, it's not on her. She's coming to help with housing. Yes, she's coming with
She
abuser
requested
partner.
not to call.
I mean,
So
yeah,
she
she was
doesn't want to
requesting not
contact the
to
police.
call.
Yeah.
I think there's no
No,
need for the
but she's
police here.
requested
There's
not
no
to
danger.
call.
But
She's
that
But there is
requested.
no immediate harm.
Guys,
There
one
is no
second.
immediate harm, right?
Requested to call. It's different than encouraging her to call.
but that's not answering her
None of the answers are
inquiry.
perfect. They are all half.
She is
Yes.
inquiring for housing, so that's not answering her need.
Good. Okay.
For what
So here they are testing for you the priority of care. They love to test this for you in your exam. You need to know what is your priority here. Is your priority here to call CAS? Even if they remove for you, Dr. Andrew, the half of the question which you didn't like, and there is only CAS, will you pick CAS here?
Why will we
I mean, if there is a history of violence,
With the same scenario, they removed for you the half which you didn't like.
I will choose CAS because even if it's history and not current violence, even its history, this might indicate future violence as well. There is a possibility still. So I'll go for CAS.
She left violence place, doctor. She left the house. So what will be the violence here? She's just homeless.
Even
And
history of violence,
the
I guess
question
we'll
they didn't
contact
tell you.
CAS.
Yes, the question, the STEM
Mhm.
didn't mention anything about the child is neglected or in
No.
imminent, just in imminent danger. Yes, from
If
her actions,
witnessing, doctor, if they are witnessing violence,
you
that's
still
also
can do it.
indication.
We need to assess the child that if it's true or not.
Yes, but
Suspicion is enough.
yes, but there is 2 points here. Will you go contact Cass while the mother, she's coming to you asking for help? You're gonna contact Cass to take her child?
Oh my God,
No,
no.
no, not at all.
No,
Not
think
the
about
first
No.
step. Not the
She's,
first step.
she's coming for help and we're okay, we're gonna take your kid.
No, but
yes.
not necessarily taking the child. They will do their investigation separately in the background.
Mm-hmm.
That's my point. Not taking the child. They need to investigate for sure first.
Yes, but the thing is here with the
That's not
Cass,
the priority.
yes.
Right now, she
The
doesn't have house. She already left the risk environment. She is not
yes.
with the perpetrator. She left. Right now is not the immediate problem. Her problem
I,
is like she doesn't have housing.
yeah, but I don't know, Dr. Steven. It seems like it was your neighbor or something. Like, why are you so sure about it?
No,
Like,
no.
What?
It's no, it's like
No, it's in the question. I think it's in the question. If you read the question really carefully, she asked whether there is any way to get help finding safe place to stay in support for her
yes.
kid.
That's what you need
So
to focus on. Everyone, you are reading the question, you are concentrating and you are looking
yeah,
nicely. All the answers could
got
be
it.
correct, but one word can change for you what you are looking for. A lady, she's coming to you, she's asking for help with something to keep her safe and so on. We cannot go ahead and call for her the police. We cannot go ahead and call for her CAS. We need to do for her what she is looking for. She is coming for a shelter to be safe with her child. We cannot just discard this or just forget about this and go ahead and, okay, I'm going to contact for you guys. Gooch. No. So even if they remove the other part, if she's not homeless, it's not our priority here. Our priority is to find her a place to help her with this crisis or something is happening bad for her to keep her safe. And yeah, the other point is if they didn't give us this option and they gave us that the lady she is coming, she's not asking about housing, but she's saying that the partner is abusing her, you're gonna
Uh,
encourage her to report to the police maybe or encourage her to report, and you're gonna contact CAS by yourself if the child was in the place or he did witness or whatever it is. This is time when you go for CAS, but you need to keep in your head in such scenarios, you need to focus on. Ask yourself what this lady came for. Did she come for an abuse or abused partner or patient or sorry, or a partner who's just abusing her in front of the kids, or she's coming to you to ask you for a housing, or maybe she's asking for a place or a shelter. So try to focus.
Doctor, I believe you should have included a social worker in one of the options because I will not do it myself. I'll involve a social worker in this case, right?
It could be social worker.
Because they
But
handle such cases
could
like
be,
arranged
but
housing and
yes,
socioeconomic
could
support.
be, but you have also resources more than the social worker too. You have resources you can just provide it, maybe shelters or whatever it is. As a physician, you will have such resources to give it or to refer the patient to it to be able to get a help. Maybe you're gonna just go for a
Got
social
it.
worker, maybe not. Maybe you have numbers, maybe you have whatever it is. So you have your options as well and resources as a physician as well too. So C could be correct as well too. That's urgently to community resources.
Yeah,
So for the intimate partner violence.
good question.
Yeah. So next point. Okay. So um I'm still working for you guys on the two gifts which I told you about it. This is different from the next exam gift, which I'm gonna just be happy to see everyone receiving. Um, I have few things I'm working on it on the same time. More things which is gonna help people who's going for the exam soon as well too, yes, as well as people who's preparing actively for this exam. So all what I need from you guys to keep working hard. I need you to find or to increase your scores in your question bank. 70, 60, I don't accept it in your questions bank. I need to see 90, 95, and so on. 70, 60, it's not accepted anymore. I need to see higher scores in the questions bank. How this is going to happen? You do questions, you revise your mistakes, you come back to do questions, you revise your mistakes, questions, mistakes. Even if you are not 100% done with revising your mistakes, next day, start to do new questions. Even if you are not 100% done with all your mistakes, next day, a new question, a new set, a new set, a new set. You keep moving. Do not say, oh, I didn't finish the set from yesterday. I feel so bad. I'm so stressed. I'm stuck. No, you are stuck because you are not moving. Keep moving. That's what you need to do. You are not done with yesterday. Yesterday is over. Now it's a new day for you. Start to do it. Do not make today as yesterday. Do something different. Start your day earlier. Start your day, okay, actively. If you have 2 hours, you can finish the 100 questions or maybe the 120, 40 questions in 2 hours. Yes, you need just to stress yourself more. So, let's start to do, okay, before we start to do, let's get another question. Who's gonna take the next question, guys?
I will take.
Ooh.
Okay, please go ahead. Somebody wants.
No, you can go ahead. You went before.
What was the final version for the previous question?
C.
C. C, signore. So, okay. Okay. Okay, Dr. Mahbouba, choose black box or TN.
Oh God.
No, I'll
Please
choose for
choose
you
black
and you
box.
answer.
Yeah, yeah, please go ahead.
Yeah. So we go for the black box.
Okay, black box. Let's see what the black box get for us. Okay, let's take this one.
Sorry, just a second. So, a 67-year-old man is brought to the emergency department by his neighbor because of confusion for 2 days. He lives alone and was recently treated with ciprofloxacin for a urinary tract infection. He has hypertension, type 2 diabetes mellitus, chronic kidney disease. His medication are ramipril, hydrochlorothiazide, metformin, and glyburide. He is diaphoretic and inattentive. His temperature is 37. It's okay. Blood pressure is 132/76, pulse 96, and oxygen saturation is 98% on room air. Which of the following is the most appropriate next step? Shows confusion 2 days.
Yes, life is easy. Take it easy and tell me the answer.
Diaphoretic, inattentive. So appropriate next step. So I go for run some labs. So I'll go for CBC and electrolytes. Also, urine infection. It was there, and so I'll go for urine urinalysis and CS again. Toxicology screen. I'll review his medication list. He's 67, quite old. He is a patient of chronic kidney disease, so I'll go check the creatinine and.
Unfortunately, or what you are speaking about is correct.
Yes.
What is the answer?
One of the following. Oh, sorry, I didn't check.
It could be
Can we get the
hyperglycemia.
options?
Is there options like?
Yeah. Let's get the options.
The
I think
options
he is
is
getting confused between the medications, taking the wrong medications.
so yes, they are giving you much things, yes. So they are giving you that he's receiving the hydrochlorothiazide, the metformin, and glyburide, yes, and they're telling you the patient is diaphoretic and inattentive. Temperature is 37, blood pressure is 132/76, pulse is 96, and the oxygen saturation it's 98 on the room air. Which of the following is the most appropriate? Dr. Stephanie, what do you think?
Doctor, I was thinking maybe electrolyte. I mean, everything that the doctor mentioned, yeah, I was thinking I will do it, but maybe either an infection source or electrolyte disturbance, just because he's in so much medication and has.
Okay, let me give you.
Yes,
So number A, check the polypharmacy. Number B is order CT scan of the head. Number C, it is check the blood glucose. And number D, it is order or obtain the urine culture. Number E, it is start intravenous ceftriaxone. And number F, it is arrange the urgent dialysis.
Check blood glucose.
C.
I
I will
think
start with C. That's
I
the
go
main.
I go with C, doc.
Mm-hmm.
it
What
could be
is F,
number
doc?
A as well.
Hemodialysis?
Yes, urgent dialysis.
Polypharmacy.
But we don't know yet
Polypharmacy.
the urea creatinine or like we don't have any lab there to start.
What do you
with.
think?
Right. I
We
will
have to do something. We'll go do blood glucose, right?
glucose.
That's
Yes.
the earliest we can do. If we think like take the other than the history and all that, because others are all intervention, so we cannot if unless we have the lab reports, we cannot go do something.
Yeah, this is a
Those are the
67-year-old and
basic.
he's coming with diaphoresis
First
and
of all,
confusion. So we'll check glucose first.
Yes.
so
I
here
think
to
elderly patient, we also need to look for polypharmacy
that's
first.
correct. Yes, that's really nice. But which one you're gonna pick now from the options?
Doc,
Option
do
A.
we use
glucose.
metformin in CKD, doc? Do we use metformin in CKD?
No.
I think you are worrying about lactic acidosis or
Mhm.
Yes.
kidney problem. Yes.
Yes, sir.
Not recommended less than 35.
So, but what you're gonna do
Yeah.
in the options
BGF.
now? Yes. What
Checking
you gonna
blood
do?
glucose as the patient using the bride, that is really danger for the kidney, I think so.
Hmm.
I think we need to start
Come on,
by
please. Come on.
first. A, B,
Yeah, I
C.
think we need to
Check
check the
blood
glucose
glucose.
first.
If the
Oxygen,
patient be
glucose.
hypoglycemic, then we will be give some IV.
Diaphoretic.
So
We
that's
have to
what
do the
you,
vitals first.
yes, that's what you are falling in once you walk to your lovely day. You are not sure, am I going to go with this answer? Or this is gonna be my answer? What will I do here? What first it's gonna be your first step? What I need you from today and going everyone, I need you to focus more on the questions. I started to improve for you from the feedback which I got from the 35 doctors. I started to improve for you the questions, and you're going to be seeing this in your upcoming tests and so on. Even from the materials and so on, I started to take a feedback from people who did go to the exam, the 35 doctors, and even the few who didn't have a luck. I started to take a feedback to improve our way more. Every time I'm doing the same thing. So I need you to focus, and from now on going, get out of the mentality which the questions bank they are building inside your head. I need you to think about each question you are doing. What is the step number one which you are doing here? What is going to be your priority here? How you going to do this? I need you to imagine yourself as you are in the same situation. You are the treating physician. You have this situation in front of you. This patient is presenting to you. Your first step, do you think that you're going to go ahead and ask about the polypharmacy?
No.
It's not your priority now. It could be right. but it's not your priority now. Your priority to see what's happening to this patient to stabilize him first. Yes. So the correct answer, it was check about the capillary blood glucose level, yes, or the glucose level, whatever they're gonna just write for you there. Why this is correct? To find out that this is the correct answer for you as well too, you need to be able to find out and observe the symptoms which they give to you in the vignette. So the giving you the patient is diaphoretic, confused, inattentive, yes, and they wrote for you that he is taking gilibride and recently started. What he recently started, guys?
Ciprofloxacin for
Ciprofloxacin.
urinary tract infection.
Yes. So once you get an elderly with a chronic kidney disease and he or she, they got this combination, you are worrying about. Gilibride, before we go from here, what gilibride is, which group? Guide. Which
Meglitide.
guide?
No,
No.
GI.
Sulfonylurea.
Sulfonylurea. Guide. Yes.
Sulfonylurea.
The G
Yes.
on the beginning, and that's why we made a dash. So start with the G and it ends with the I. That's why it's important for you to remember what we did in the session for diabetes. So you are worrying here about sulfonylurea hypoglycemia. You need to be able in your exam to pick this drug because once you find out it's sulfonylurea, you know that they love to question you about the hypoglycemia. Because why sulfonylurea is causing hypoglycemia, guys?
Because it's
It is not
independent.
Independent. Very nice. Very nice. That's what you need to keep in your head. Yes. So ciprofloxacin or diaphoresis. So they love to give you diaphoresis, confusion, because they know that everyone you're gonna see diaphoresis and confusion. Oh, I know it. It's delirium. Take it easy. Yes. You need to walk to your exam while you are relaxed. You don't need to be just agitated there. Yes, forget about the restlessness syndrome or anything is happening. Please be quiet in the exam. Do not just be fast. Do not quickly pick the answer because you know it's a similar question. Maybe you miss the similar question easier than you miss a hard question. Maybe hard question because you thought about it, you're gonna solve it correct. Easy question because, oh, I know it, I saw it. You pick a wrong answer and you walk. Yes. So look nicely, see what they are asking you, and yeah, focus on what is important. Okay, let's start, guys. Okay. Let's start. Are you awake, guys? Are you awake? Anyone awake?
Yes,
Yes.
we're here. Awake and
Yes,
ready.
doctor, we are back.
Okay, okay. Okay, this table, just go through it, please. Basically, what they are trying to tell you here is, or what you need to focus on. If you have a patient who's coming to you with a thunderclap and so on, yes, and you are suspecting that it's maybe subarachnoid hemorrhage, what is your investigation for the confusion?
না ইমরান ও কি করতে যাচ্ছে তুমি বুঝছো
Dr. Mahbouba, your mic is open.
sorry guys sorry very
So they love to ask you about the investigation. So you need to see what they wrote for you here. CT, LP, and your angiograph if your CT is negative and LP. The same when you are taking or you are getting a patient with a TIA or stroke, we're going to speak about them, and you find a focal neurological signs. What you going to do here? CT or MRI.
Yeah.
Yes. The same with the meningitis. In my just opinion, this table, you need to gram it nicely. Yes. So how you going to gram it? You need to start as I remember it myself. You're going to write CT. Yes. And you're going to write second line. So CT, under CT, you're going to write all the etiologies which is written for you here, which you are starting with the CT. Yes. So CT plus LP. You're going to write under it everything. Yes, that's going to be easy for you to study later. Because you're going to remember that all what you have created on the sticky note, which you're going to have in front of your eyes, falling under this, you're going to start with the CT. Yes. So CT, definitely, you know, if it's a vasculitis and you have a skin rash and active joints, they're writing for you ANA, rheumatoid factor, and ANCA. You know it. Yes. If it's not your answer, second line MRI. They love to put for you second line MRI. The point which you need to remember here, we studied yesterday, seizures. What you're gonna do? Will you do CT or will you do EEG? EEG. And then
easy
yes, you go for CT or MRI. Yes, CT or MRI. Definitely, if you are looking for any focal presentation for you, so you're gonna go ahead and do your CT. We did study it in status epilepticus yesterday. Do you remember it, guys?
Yes.
Yes, and we did revise where else we did study it. So you need to remember it as well too.
Yes.
So you need to have this small sticky note in front of your eyes, CTLP. Yes, write on it all the etiologies, and you can mention with a small line just the presentation. I already created for you a small summarized table, which I did attach it for you in your capsule coming from here. But I need you on the same time to go ahead after the session and manually just write it down as well too. Next. So okay. Okay, yesterday we did study seizures. I hope that everyone did study it nicely. We have done it, so you are not able to miss, or you don't have an excuse to miss any question about it. So, next question. Who's going to take the next one?
Me.
Okay, doctor. A 29-year-old female, she is controlled under vertebrate. The lady, she is coming to you today because she is wishing to be pregnant. What will you do?
I think you need to change the medication she's on. I just can't remember what medication you changed to. Mm. Do you have
Lamotrigine,
options,
maybe?
doctor?
So the dilemma which you are falling in here is she's controlled, Dr. Andrew. What will you do?
Stopping abruptly might cause recurrence of the seizure. I believe I will maintain her on another anti-epileptic, but not valproic for sure. It's teratogenic. Safer alternative would be lamotrigine, or might be other options, but lamotrigine is my first go, and it will follow up with a specialist. I will not handle this case alone. She needs a specialist.
That, and we also need to commence her on folic acid.
So you have here two things you need to keep in your mind. Dr. Stephanie, what is your answer?
Yeah, doctor, I think, well, I was just like reviewing everything. So, but proic acid, like, it's really teratogenic. So, I mean, the choice of antiepileptics for pregnancy will be lamotrigine, yes, and I agree, like, increase the dose of folic acid. But again, this is a dilemma that I always come through. Like, this patient is already controlled, like,
Now you need to write it down so you won't forget about it, Dr.
yes,
Stephanie,
thank you.
honestly. Yes. Dr. Aksana, what is the answer? Dr. Aksana, please. Come forward. Tell me what is the answer.
The doctor is at work.
Okay, she's at work. That's totally fine. Okay. Dr. Curran, before I say the answer, tell me the answer.
Yes, doc. So valproic acid, it causes neurotubular defect, right?
Dr. Curran, I need from you, what will you do?
If she's not pregnant, I switch her to lamotrigine. If she's pregnant already and she comes to me on valproic acid, I increase the dose of folic acid and monitor,
Okay.
close monitor. But now I switch to lamotrigine and
Okay.
folic acid.
Now we are specifically speaking before pregnancy. Please write it down. Before pregnancy, it's not blood pressure. Before pregnancy, please write it down. You have two conditions here. Either you can, either you cannot. Either you can switch, either you cannot. If you can switch, yes, what is the best next step for you? No one did mention about it. You need to start with the periconceptional counseling. You need to go ahead and give
Folic acid.
folic acid plus switching. Yes. So we won't stop it right away, yes, but usually they are just having a way just to taper it and just give the other drug too, because if you stop it right away, you might give complication to
Yes.
this patient. If you cannot, so if you can stop or switch, do your counseling, give your folic acid. If you cannot, what is the conditions which you cannot?
Of severe epilepsy.
Well controlled on the valproic acid.
Maybe that the patient has been in the past switch or change and then
The patient is already pregnant.
No, no, no. We are speaking about before pregnant now, Dr. Akron.
Okay, okay,
Specifically, I wrote
okay.
it here. Yes,
Right,
because
right.
when she's pregnant, we're gonna do other things too.
Yeah. Severe seizures, severe epilepsy, history of severe epilepsy.
Maybe has been resistant to treatment or
Allergic to other medication.
The only exception for you here, which you are not gonna switch here, if you have tried other drugs before and it was failed.
Yeah.
They tell you that you tried it and it was failed. Or they tell you that the patient cannot tolerate any other drug. Or they tell you that the patient seizures is worsening with other drugs. So only 3 exceptions which you have here. In this condition, what you're gonna do? So you cannot. So the answer here, you cannot switch. What are you gonna do here?
Increase folic acid.
the dose of folic acid.
You increase the dose for folic acid and you forget about the most important point.
Pre-counseling.
Yes, counseling here. Counseling and folic acid, it's coming to you on both sides, right and left. Yes, the only difference that here you can switch, here you cannot switch. Yes, so we're gonna speak about it later, what dose of folic acid you're gonna do here or what you're gonna do. But do not keep this lady because she's only controlled on valproate. Please give her the counseling and give her the folic acid, and you can switch. Yes? So never abrupt stop it. And the next question which is coming to you. The next question. So the same lady who you did keep her on or you switch it for her the medication. Or maybe the lady you did keep her on valproic acid, she's coming back to you. What you gonna check about when you're gonna check about? She's coming back to you. She's pregnant now. What you need to check about?
AFP, doc, do AFP.
MSAFP. What is MSAFP?
Maternal serum
Maternal
alpha beta
serum.
protein.
Thank you so much. When you do it, you need to remember it. You need to have it on the same note which you wrote on it, the PP. When you gonna do it?
15, I think 15 to 16 weeks.
So yeah, so it's between them, yes. So it can be the best time between 16 to 18. You can do it between the 15 and the 20 weeks, anytime between it, yes. It's totally okay. What else?
Anomaly scan, you mean?
How you gonna do the anomaly scan?
Ultrasound.
When you gonna do the ultrasound?
We do it 18 weeks, 18 to 20 weeks.
18 to 22. So remember 16 to 15, that's the time you do your MSAFP. Remember, if you are looking for the anomalies, you're gonna use the ultrasound. There is 2 points here. If you are worrying about the neural tube defect or they are giving you the age appropriate to screen for the MSAFP, just go ahead and do it. If they give you 18 weeks and so on, and you are worrying or you did check about AFP, yes, MSAFP, you did check about it already, your next step is to do the ultrasound. Yes, they love to ask about when you're gonna switch and so on. They ask about what you're gonna do when you switch. They love to ask about which test you're gonna do here for this lady. You need to remember the age appropriate time for both of them. You need to remember what you are doing the test for. So if they are asking you or you are screening for the open neural tube, the MSAFP is your answer. If they are asking you about the test which is looking to or for the structure defect, yes, then you're gonna go ahead and do your ultrasound. So, yeah, did you get, guys, when you're gonna do ultrasound and when you're gonna do AFP?
Yes, ultrasound on structural defect and MSAFP for open neural tube defect.
For screening for it, yes. Yes, that's totally right. So, okay. Yeah. So please remember what we did now. This is different than the lady who's coming to you and she's pregnant already. I need you only to remember this now. Did you get this point, everyone here? You cannot walk to your exam without you have this and a small sticky note in front of your eyes. Did you get it all?
Yes,
Yes,
doctor.
doctor.
Yes, doctor.
Thank you so much.
Sorry, can you recap?
Please recap
Can
it,
you
Dr.
recap?
Karan.
Can
Dr.
I
Karan,
recap,
yes,
doctor?
please. Yes.
So
Please,
before
thank you.
pregnancy, there is two options. We can switch and we cannot switch. So for we can switch, there should be peri-conceptional counseling and folic acid given. And where we cannot switch, there will also be counseling and folic acid. And there is three condition. Other drug she tried but failed. Then patient cannot tolerate any other drug, and patient seizure is worsened with other drug. So for open neural tube defect, we are doing SAFP, maternal serum alpha fetoprotein test, 15 to 16 week. And for seeing the structural defect or anomaly scan, we are doing ultrasonogram 18 to 20 weeks.
Yeah. So you need to determine if you can switch for this lady, so you can go maybe for lamotrigine or whatever it is, or you cannot switch for this lady and you're gonna keep her on the same drug, but you're gonna counsel her as well too and do for her the folic acid. So the next question which I need you to know here is,
Dr. Dara,
yes, Dr.
here now after stopping valproate, is there a specific time period she has to wait before becoming pregnant?
Ask again, Dr. Drenendra, please.
Now we are switching to lamotrigine, right?
Mm-hmm.
Now, so her blood level of valproate is already there. Now, is there a specific advice we give? Okay, so you need to have a say like take precautions, contraceptive methods until X amount of period before you try to become pregnant again or something?
Yes, that's why you are doing the counseling for her. Counseling, it's not only about the risks, but you're gonna tell her maybe, okay, because the effect of the valproate is still gonna be on the blood, yes. You can tell her that, okay, wait, do not get pregnant now, till you be able to, or till we be able to switch you totally maybe on a safer drug to avoid any risks, yes. So you need to cross taper here. That's what you're gonna do here. So you're gonna just taper the drug here. So, and you are starting the other drug slowly. Yes. So, and when you are saying slowly, You are starting one drug slowly, and the other one you are reducing it slowly as well too. Yes, you are aiming for monotherapy, but in this time you are trying to taper. You cannot stop the valproate right away. So you're reducing the valproate, and you are giving just gradually your maybe lamotrigine or the other drug which you're gonna go for. So usually it takes up to 2 months, from 7 to 8 weeks. So you can advise this lady to not get pregnant till you switch her totally on lamotrigine.
Sorry, please, quick question. When you taper, do you taper and then, as in while tapering, you start the other medication? Or you
Yes,
taper completely
because
before?
no, you cannot taper completely.
Mhm.
You are starting slowly and you are tapering as well too
Reducing.
gradually.
Okay,
Yes,
awesome.
yes.
Thank you.
Yes,
Thank you.
because you need to keep her, because the thing here is if you wait, you don't add for her slowly another drug and you're reducing the dose, maybe you're gonna get this lady to seize again and you don't want this. That's why
Want
you
it?
are
Okay.
giving and yeah. So I don't think that they're gonna ask you much about this as they love to ask you about what you're gonna use here. If you go to your options and you don't find lamotrigine,
Levetiracetam.
Levetiracetam, yes.
yes, Dr. Andrew's favorite drug.
Yay.
Yes, if you don't find lamotrigine, you still can go ahead and give this patient living. So, okay, next question. Next question. Who's gonna take it?
I want to take
So, if you have a young male who's coming to you with a dementia, what is the causes?
young alcohol, fever. Fever is for child, but alcohol is for elderly. And as it's adult, so alcohol can.
You said dementia with
No,
delirium, Dr. Abdullah.
I'm waiting.
Fever for child, alcohol for
So,
middle age, stroke
yeah,
for elderly.
what you was just speaking about, it's called
You asked about dementia cause.
why you and what you mentioned, Dr. Mira, what it was?
Seizures.
Seizure.
Yes.
The problem that you
Yeah.
know the answer, guys.
Yeah.
So please answer my question now.
Any infection, neurocognitive disease,
Neurosyphilis,
Okay.
Down syndrome,
Syphilis, what else?
HIV,
First one which you
alcohol.
needed to tell me, Dr. Mira, without doing any effort to think, it was down. No one did say it
Alcohol.
first.
Down
Down.
syndrome.
Yes.
Oh, Down
Down.
syndrome.
Yeah.
No one did mention down. It
I
was number one.
did.
Okay, down.
Neurosyphilis and Down syndrome. Yeah.
Okay, down. So if you don't find down,
neurocognitive disease,
The
Alcohol.
Jacob.
if
Alcohol
you
damage?
okay. Down, because down usually you're gonna say that these guys they're gonna present with an early Alzheimer's. What is the other disease which you think about next to down? Because you need to write them down. So because of down, you need to
Edward.
write it down. Not Edward.
acromegaly,
Otto.
Huntington?
Huntington.
Oh, Huntington.
Huntington.
Both
HTTG.
of them. Yes? So please write them down. Now, if you are speaking about infection, and Dr. Stephanie said a neurosyphilis, what else? What is the brother you're gonna add?
HIV.
HIV.
HIV. Yeah.
HIV-associated neurocognitive disorder. So what else different than infection and genetic? Please do not repeat anything we spoke about. Give me something new. Infection and
Wilson.
genetic, we are done with it.
How about Wilson, Doctor?
Jacob
Wilson?
disease, Jacob, what's the name of that?
Prion disease.
Rhodes Jacob?
Yeah, prion disease.
I will take Rhodes Jacob later, not here.
Oh, okay.
What
How
else?
about substance use?
Wilson disease, Doctor?
What substance use?
Cocaine,
Alcohol.
alcohol.
Cocaine or
Cocaine.
any chronic substance abuse could cause it as well to dementia, or it could
be
be
inhalants. Inhalants.
it could be if it's a chronic use too, because we're speaking about dementia, not delirium.
Yeah.
Yes. So alcohol related cognitive disorder. So it's not just because the patient got withdrawal. Oh no, it's delirium. Yes. But if it's just a chronic user of alcohol, patient, he's not stopping, he started to have a problem and he's keeping on it, so it's a very bad use. It could be too. What else? We spoke about infections. Please write it down because someone can
Vascular.
repeat it. We spoke about genetic. We spoke about substance related. What else?
Vitamin deficiencies.
Vascular disease.
What vitamin deficiency, Dr. Stephanie?
B12.
B12.
B12 vitamin deficiency. What else?
Hypothyroidism.
Vascular stroke.
Hypothyroidism. Hypothyroidism is very important. Please write it down. What else?
Wilson.
TBA.
Prader-Willi?
Oh, genetic.
We are done with the genetic.
Traumatic brain injury, maybe?
Selective mutism.
Selective mutism.
I don't know if it's not traumatic. I don't know what else.
What about Alzheimer's, doc, and Parkinson's?
But Parkinson, do you find Parkinson in young patient on Alzheimer?
Oh, young. Oh, no. Young patient.
Young.
Any tumors, Doctor?
Yes, brain tumors could be.
Okay.
Normal pressure hydrocephalus. You need to remember it. If you don't know anything about normal pressure hydrocephalus, make it your target for today. Study it. So, brain tumors. Yes, I have a session coming for you guys about the brain tumors. But if you didn't know about it, please go study about the brain tumors.
Oh, Wilson's, doc.
Wilson's, but I would take multiple sclerosis,
Yes.
autoimmune encephalitis, traumatic brain injury, and brain tumor before it. Yes. I need you to remember that a vitamin B12 deficiency. I need you to remember hypothyroidism. I need you to remember the normal pressure hydrocephalus.
So the dementia.
That's all you are speaking about dementia.
No, I just was saying the
Oh,
pressure.
you are saying pseudodementia.
Yeah.
So yes. So yes. So I have added to you all of them to your lovely capsule. So I added it to you so you can study it once more. You can revise it, yes. So why this is important for you? Someone come forward and tell me why what we just discussed is important. Dr. Isabel, please come tell me.
Maybe because we find these pathologies really often.
It's not because of this. Think about the exam side. Why this is important for you. Everyone,
I mean,
use
these
your
are all
brain.
serious conditions. So if we get a patient young with dementia, we should think on one of those because it's not common to get
Very
a
nice. You need to think of this. And when you think about this, You need to use this for what, Dr. Stephanie?
Just for stage or differential diagnosis and
Not only differential
COVID
diagnosis, you
management
need to do what? What is the best next step for you gonna be?
The
investigate.
investigation.
Thank you so much.
Investigation.
Now you know why we did study them. Because once you get a young patient with a dementia, now you did study the workup which you need to do with other way. Now you did study HIV, you're gonna go and do the test for it. You're gonna do your VDRL, yes. You're gonna go maybe do the vitamins, TSH, CBC, electrolytes, and so on. Yes, this is the initial labs for you. That's why we spoke first about the genetics and so on, the conditions which we spoke about first. Yes? If you don't find this, yes, so it's important for you to remember things as with just what we discussed. Genetic conditions, yes, and we did speak about your infections. So it's infections, genetic conditions, and then substance related. Three things which you need to think about, keep it in your head. The other thing, if you don't find any of the conditions which we spoke about, so the first 3 points, it's your initial investigation. That's why we spoke about the CBC, TSH, and so on. If you don't find anything, what is the best next step? Now you go to check about the brain. Maybe you're gonna go ahead and do your MRI. Brain MRI, maybe you're looking for a tumor, whatever it is. Yes. So if you suspect that there is something else is happening, so if you think that there is inflammation or infection, what could be your answer here?
LP.
LP. If you are thinking about a patient maybe with a genetic condition, Huntington, that's why if you don't know a single word about Huntington, please go and study it today. I believe we need to do it today as well too. If you don't know a single word about Down, please write it down, go search for it. You need to be able to recall all the complications, all the findings which you're going to find with your Down and so on. So you need to be able to challenge your exam like this. Yes. If you don't know about it, it's not bad. Yes. Maybe you didn't study, maybe you forgot about it, whatever it is. Go now and turn this to be a note for you. Next point. Next point is very important. So, how we differentiate between the mild, please, did you get guys the before pregnancy and the lady she's coming for a counseling or meeting and the causes of a young dementia patient?
Yes, doctor.
I'm gonna ask someone randomly to repeat. Please start write your notes. Next point is very important. Next point.
Doctor, sorry, did you talk about like what we do when the patient is already pregnant and
No. I
No,
gave you
okay.
only today the before the pregnancy.
Oh, okay.
Yeah. So next point we're gonna speak about here before I go to anything else. So what is the reversible causes of dementia?
Vitamin B12.
Or
Substance use.
Hypothyroidism,
hypothyroidism.
Hypothyroidism. Yeah.
normal pressure hydrocephalus,
Okay, how about syphilis?
Infections.
Yeah.
Infection. So if how about brain tumor?
Depending
yeah,
on the stage and size of it.
Okay, and how about the brain abscess?
subdural hematoma,
It can be
Yes.
treated.
chronic,
How about
Yeah.
medications?
reversible,
Yes.
Reversible.
Which medication can cause dementia?
Opioids?
Benzos, maybe? No.
HIV medication. Yes. Demand.
So remember anticholinergics.
Anticholinergics. Yes.
Anticholinergics.
Yeah.
What else, guys? What else is reversible? So we spoke about, you need to write them. Yes. Normal pressure hydrocephalus. We spoke about hypothyroidism. We spoke about the vitamin B12. We spoke about maybe hepatic or uremic encephalopathy. Maybe you are speaking about CNS vasculitis. Maybe you are speaking about syphilis. Maybe you are thinking about brain tumor. Maybe you are thinking about anticholinergics. What else? Squeeze your head, please. Try to find the information.
Alcohol, if it's a wernic, is reversible.
Something related to sleep.
Obstructive sleep apnea.
Thank you so much. If you don't know a single word about obstructive sleep apnea or central sleep apnea, please study it today. Please study it today.
No
Turn it
sleeping
to
for QE1 too can cause dementia.
yes, hopefully it's not causing dementia. So yeah, so okay. Irreversible causes. What is the most common irreversible cause?
Down's syndrome.
It's a big
Alzheimer.
problem if Down syndrome is very common. What is the most common irreversible cause? We are not speaking to say Down syndrome about age appropriate.
First
alcohol
cough, dementia,
Alzheimer.
Alzheimer's. I thought it was
Alzheimer's. Alzheimer's.
Parkinson's.
Alzheimer's. Then you're gonna go for Lewy body, and then
Parkinson.
no.
Huntington, maybe.
Frontotemporal.
Frontotemporal.
Yes. Frontotemporal. You need to remember them one by one like this. Yes. So if they ask you what is the most common cause of dementia, it's Alzheimer.
Alzheimer. Yeah.
Now, if they change, you need to have all the information which I'm speaking about down in your notes. Next point. Next point is if they ask you what is, please concentrate. What is the most common cause of a rapidly progressive neurocognitive disorder?
CJD.
Creutzfeldt-Jakob.
Yes.
Creutzfeldt-Jakob.
Next one.
Lewy body.
Vascular dementia.
Vascular dementia.
Which one, Dr. Abdullah? Vascular dementia?
Lewy body is the next one.
I think so, but I need clarification.
Not Lewy body.
No?
Vascular, okay.
Unless I got dementia myself. What is the most common cause of a rapidly progressive neurocognitive disorder? Rabbit.
Alzheimer?
No,
No. There is two difference between the two questions, guys. That's why I'm telling everyone, wake up.
Jacob.
Prion disease.
So why I'm telling everyone wake up? Because we are speaking about two different conditions. We are speaking about first one. You are speaking about a condition. What is the most common cause of dementia? Versus the second one. What is the most common of or cause of a rapidly progressive? It's rapidly progressive. So it's Creutzfeldt-Jakob. Then it's gonna be the frontotemporal. Then it's gonna be the tauopathies. Then you're gonna have the diffuse Lewy body disease and then Alzheimer. You need to have both of them. They are mentioned in your book.
So I just missed the third number. So
say
after
again, please.
Creutzfeldt-Jakob first, then frontotemporal, then tau body.
Yes.
Okay.
So tauopathies, and then you're gonna have the diffuse Lewy body, and you have Alzheimer. It's mentioned in the book too. So next point which you need to remember here, how we differentiate between the mild and the major neurocognitive disorder. That's what you need to keep in your head. So I need you to think about the next, guys. Please concentrate. What is the key function difference between the mild and the major? That's what we're going to speak about right now. Which screening test is more sensitive for early cognitive decline? Are you going to go here for MMSE or MOCA? What is the reversible cause which you must exclude before diagnose your neurocognitive disorder? That's why I gave you the list of the reversible conditions. Are cholinesterase inhibitors recommended for mild neurocognitive disorder? 4 questions I need you to think about. We need to find the answer for it to digest this topic. So, first of all, how to differentiate between mild and major cognitive disorder?
Dependency, mild,
Yes.
Or
Yes. You're gonna go ahead and look for the activities of daily living. What is the activities of the daily living?
bathing,
shopping,
shopping,
Bathing, dressing, toileting,
bathing,
eating,
dressing,
sleeping,
toileting,
grooming,
medication.
So, yes. So, because if you look under the mild here, they wrote for you it's preservation or minimal impairment, different than the major. If you think about the major, yes, if you come down here and you look for the major, you're gonna find out that there is impairment where it is. So it's here. Do you see it?
Yes.
That's how you differentiate between them, first of all. Second, the second point here is mild. You need to find a cognitive decline. Please write it down in more than one domain. What's the domains you're going to look for here? That's what you need to mention in your notes because I'm going to look into each one of your notes after the session. The first domain, it is memory. Second one, it's the executive function. Third one, it's the attention. Fourth one, it is visual or visual, the visuceptal. The last one is the language. Yes. So I need you to tell me. I need you to tell me what is the meaning of executive function?
executive function, like they
Yes.
can follow command and do certain activities or
Planning,
Being able to do some complex activities.
Executive function like means planning, organizing the behaviors. Sorry, organize and regulate the behavior to achieve something.
So, okay.
Higher level cognitive processes,
Mm-hmm.
like the doctor said, planning, organizing, and monitoring, or all those adaptive behavior that achieve goals.
Okay.
It has to do with organization and emotional regulation as well.
Executive function, or you need to think about planning and organizing skills. So the patient is able maybe to solve problems. The patient is able to stay focused, yes, All these things you can keep it under your executive function. Plan steps, make decisions, all these executive functions. Think about it. If you have a management and you have an executive board, what they are doing? They are planning.
Planning, taking decision.
Yes, planning, taking decisions, and so on. So remember it this way. That's how I remember it in my brain. So the next point which you need to remember here, what is the meaning of the visuoseptal skills?
Like we can imagine in our brain, if we say there is a house, so we can imagine in our brain. So visuoseptal
Its
skill.
ability to understand where things are in the space. Maybe judge the shape, maybe judge the distance, maybe judge the direction. This is the visuoseptal skill. Yes? So maybe they are able to park the car. Maybe they are able to find their way to home. Maybe they are able to recognize how things is fitting together. So you give them maybe a pen and you remove the tip of it or the cover and you ask them to collect or just to combine them back. If they are able, maybe you are saying, okay, they have the skill or it's still preserved. Yes? What you need to remember here for me is we spoke about the cognitive decline. Please write this information
Hello,
down.
John.
Please, guys, keep the mic close. If you have a patient with the cognitive decline, please write it down. And they tell you that this guy, he is having a preserved independency. You're going to think about mild or major cognitive disorder.
Mild.
Mild.
It's going to be mild because your independency is preserved. When you say that there is independency preserved, it's written to you here. This means that they are able to do their tasks. But you have a cognitive decline. Maybe they have a problem with memory. Maybe they have a problem with the executive function, the visuoseptal skills, yes, things which we spoke about that you need to remember. But the patient still can be dependent. That's how you're going to say it is mild or minor. If they give you a patient with a cognitive decline, any of the things which we spoke about, what is the things which we spoke about coming under the cognitive, Dr. Stephanie? Wake up.
Memory, attention,
Memory,
vision,
attention. What else?
Executive function,
Executive
tasking, and language.
and
function.
language.
Very nice. Yes, very nice. If you find a cognitive decline here, and they tell you that this guy, he lost independency, lost. Please write it down. Will you think about minor or major?
Major.
So you're going to think about major, you're going to think more about dementia.
Major.
Yes? So in your questions, look for the daily activity living, look for independency. Write it down, please. Because when you look for your independency, if you find the patient independent, you're going to say that this guy or this patient is having a mild problem. Did you get it, guys?
Yeah.
So it's very important. Yeah, please concentrate because I'm going to ask someone to repeat what I'm saying. So there is two types here, or they're speaking about subtypes, which is amnestic subtype. Yes. And there is non-amnestic subtype. So amnestic we are speaking mostly with the conditions which is associated with. They wrote it for you down here. With Alzheimer, non-amnestic subtype, you're speaking about the attention, the executive, the visual symptom. So more you can think about the amnestic ones, it's gonna be more going for your favorite, your major. The non-amnestic subtype, it's more coming under your mild, because on the mild we are speaking about preserved the independency. Yes, someone gonna jump in, Dr. Alzheimer, it's a progressive. Yes, it's a progressive. So what you gonna categorize Alzheimer? Will you categorize Alzheimer under a minor, or you're gonna categorize Alzheimer under a major? You're gonna
Major.
go back to the rule we spoke about. If the patient is having cognitive impairment, plus it's preserved the independency, it's still considered for you a mild. If the patient is having a cognitive impairment and he lost independency, this is you're gonna consider it major. Did you get it, everyone? So this is the golden rule for you here. To find out it's a minor or it's a mild or it's a major. Yes, please look for it in each question. That's gonna make your life easy. So if they are giving you a patient who's coming to you with, what do you think the symptoms is going to be for you guys with the mild cognitive?
Like he forgetting the things like car keys,
Mm-hmm.
Memory
remembering the
issue.
days,
So please
lost the days.
concentrate here. The road for you depression is very common. Irritability, anxiety, aggression, and apathy. I need you to remember these presentation. Why? Because once you see in your exam elderly is presenting to you with these presentation or these symptoms, you're gonna go ahead and think, okay, am I dealing with a psychiatric problem or it is a mild cognitive problem? What they are trying to test you about. Yes. So why we are asking this? Because the next question is gonna be, if they ask you about the initial screening test, what is gonna be your answer?
Mocha.
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 Why you gonna go with mocha here?
More sensitive.
Because yes, mocha is more sensitive. If you don't find mocha, can you go for MMSE?
I think that's diagnostic.
Yes,
No, you could
MMS.
go with MSE, but MSE is less sensitive.
Less
That's the
sensitive.
only thing. Yes. So if you have a patient who's presenting to you now with mild, and we did speak about how you differentiate between the mild and the major, I'm gonna ask someone to repeat. We have differentiated, and you did know how you're gonna recognize it super easy. Then when they ask you about the initial investigation, that's gonna be your MOCA, because it's more sensitive. So what else you gonna do here?
For
We can
dependency.
investigate for irreversible causes, just to start with, just to make sure that there is.
So once you get a patient with a cognitive decline, they love you to go for the next.
Dependency.
To do your MOCA, and as well as to concentrate on the point number 2 here. Clinical interview with the patient and caregivers, including family history. Did you get it, guys?
Yes.
So it's very important. Neuroimaging, that's if you need to exclude something structure, you're gonna go for the CT, maybe non-contrast. Or if you don't know what is the cause after interviewing, after MOCA, after everything, you can go maybe and think that, okay, I'm gonna go ahead and go for MRI. Yes. What is your follow-up here? What is your follow-up? What do you think the follow-up what you're gonna do here?
Monitor cognitive decline.
What is your follow-up?
It could be depending on the cause of dementia.
A 65-year-old patient is coming to you with a problem to park his car, but he is able to get his tasks daily done. What is your answer, Dr. Stephanie? What it is?
That's a mild.
Mild, because it's still the independency, yes?
Yeah.
You have a decline in the cognition, but you still have independency. Very nice. What is the best next step for you for investigation, Dr. Stephanie?
So I will start maybe with the lab basics. So just to kind of like take out the reversible causes of cognitive decline. And we can
There
start
is something more important for labs here.
for labs.
I test.
B12.
For the lab, maybe we can do the B12,
Okay.
the thyroid.
Okay. So the initial screening, what is your initial screening, Dr. Stephanie? That's what you need to remember.
Vision and
like vision.
This is your MOCA and MMIC. Which one you gonna do here? So remember the initial screening, Dr. Stephanie.
Okay.
That's your initial screening.
Okay.
Then you can go maybe for the baseline workup, as you are saying. Do CBC, TSH, B12. So you are just checking if there is any other cause. Very nice. If you find your MOCA abnormal, we're gonna go for the management. I don't need from you the management now. I need from you after you did your management. What is your follow-up here?
Clinical interview with patients or caregiver.
Patient came to you, you said it's mild, you did your labs, you did your MOCA for the screening, you find okay it is. Then you did manage him, you did just finish your management. What is your follow-up here? Dr. Stephanie.
Cheers, doctor. 1 second. Just I cannot talk right now. 1 second.
Okay. Dr. Corin.
Yes,
to
doctor.
look for the chronic problems like hypertension,
Is this the
diabetes.
follow-up, doctor? That's not the follow-up. When you're stuck in your exam, Dr. Corin, what is one thing you will wish to have in between your hands?
The
Could
Toronto
it be
Toronto notes. And if you look under your left hand, which you need to raise from your book, read for me this line, Dr. Corin.
Okay, if abnormal, follow up in 1 year to monitor cognitive and functional baseline.
And then after the exam, you come back and you say, oh, they are asking between the lines. Did you find out where is the between the lines coming from? Yes? Did you get this point, everyone?
So
Yes, sir.
what is abnormal? The score?
You are speaking about your MOCA or MMC.
Okay.
We're going to speak about the score later.
Yes, that's mean, Dr. Abdullah, we will do MOCA and then after 1 year we repeat it.
Yes, you do MOCA and not only MOCA, and then you treat. While you are treating, after this, you can come later and you do your repeat the test. Yes, because we're going to speak about the management now. What is the management? So investigation, you need to remember what you are screening, what is your baseline labs, and what you're going to do here. If it's abnormal, the MMSE, yes, what you're going to do here. So treatment or the management. What you going to do with the management, guys? So you did your MOCA, you did your basic labs, and definitely you can go ahead and do your neuroimaging if you're trying to rule out any structural lesion. If you don't find anything in your MOCA or in your labs, maybe if you don't find the cause. If you found the cause, what is the treatment?
First, treat the reversible causes.
What is the reversible causes?
Vitamin
All what,
deficiency,
yes,
hypothyroid.
all what we spoke about, thyroid deficiency, all what we started the session to speak about. Do you remember it?
Yes, yes.
Yes, that's why we spoke about the reversible causes. Yes. Someone gonna jump in, doctor, we spoke about reversible causes for dementia. Yes, but do you think that if it's something reversible, will they be a very severe dementic patient who cannot do anything? Or it's gonna be just gradually happening and you can stop it?
Will be a
That's mild.
It's gradually. Dementia always it's gradually. So maybe it starts mild and it turns to be a major later if you don't treat it or if you don't recognize it early. So you need to remember.
Sorry. What was the answer for the follow-up? When are we follow up with it?
Under your left hand, Dr. Stephanie.
We are follow up after one year.
1 year. Okay.
Do you see, Dr. Stephanie?
Yeah. So if our MOCA is abnormal, then we follow up in 1 year.
Yes.
Yeah. Oh, thank you.
Did you see where it is in the book?
Absolutely. Thank you.
Okay. So you're gonna go ahead and treat the irreversible causes first. So that's why we spoke about all the irreversible conditions, vitamins, thyroid, all the medications maybe. So that's why it's very important, the discussion which we did in the beginning. The second point which you need to remember here is the non-pharmacological treatment. What it is? Exercise treatment. So exercise, how long you're gonna tell this patient to keep exercising? Exercise training for 6 months. Yes. And they wrote for you here a cognitive engagement. What is the meaning of the cognitive engagement?
Maybe like social activities.
Maybe, or try to do maybe some brain exercises or
brain
try to do some
exercise.
puzzles and so on. Yes.
Yeah.
Yeah. So do some activities using your brain. Yes.
Doing the
So,
checklist.
yes, study the checklist, do the 100 questions, revise your mistakes and turn it to be a strong points for you. Study the capsule, prepare for the exam, study hard. Yes, all these things or skills, it's gonna be helping or it's gonna help you to go ahead and preserve your cognitive function. If you don't study, what's gonna happen?
Develop dementia.
No, and you're gonna do what?
Hyperbilirubinemia.
And you're gonna spend what?
15 years.
And you're gonna spend 15 years.
Gosh.
People who's going to the exam soon. Beside your targets for the questions, beside your targets which we are doing, I need you to go and study the MCC exams or previous exams. Please study them. Study them with the way you are not studying them because you're going to go to your exam exactly, you're going to get the same question. No. Study them just to think about it. Okay, this topic is important, maybe. This topic is important. This one is important. Yes? So if your exam in next month in April, you need to start to work on your MCC exams from now. How you going to do this? Because you have so many things to work on it now. Work step by step. Finish your daily targeted questions. Then work maybe on revising your mistakes. Be fast with both of them. You are done? Go do the MCC tests. Study them nicely. Take it as after you finish your questions for neurology, you are supposed to do next question. You can go ahead and do your MCC questions. Yes? So if you don't know how to get it or whatever it is, we can speak about it maybe after we finish the session. Otherwise, I believe that you know how to reach them out. Otherwise, we're not going to discuss about this now, but maybe later we can speak about them. All of them is mentioned, or you're going to find them on the MCC website as well too. We're going to speak more after we close the session. So that's your target, guys. If your exam in April, if your exam in May, you need to be done with these guys. So next point. So the last thing, do not walk to your exam. If you're any of the next happening to you, your scores in your question banks or your scores in the mocks 70% or 75. Do not walk. You need to get this score to increase to be 90 to 95% at least. People who was scoring 90 to 95%, there is no single one of them they didn't pass with the 35. All of them passed. Questions bank and mocks. 90 to 95%. So please, if you need help, if you don't know what you are doing, message me. Exam is just in few weeks for few guys. If you are lost, if you feel that you are just behind, something is happening to you, you are not improving fast enough, message me after the session. I'm going to help you. Now let's move on. So treat irreversible cause. Non-pharmacological, they love much to ask about it. And they think now it's super easy for you to differentiate between the mild and the major after what we just did. Yes? So if there is a high risk or risk factor for this patient, you're going to control it. Risk factors for these guys, what it is? It's written for you up here. They are speaking about these guys. Hypertension, diabetes, or obesity, or it could be vascular disease. So you're speaking about stroke or whatever it is. So you need to risk control it. Yes, we're not speaking about the risk control it here, but remember for now that you need to risk control it. So which medication here? Are you gonna give a patient with a mild? That's the first 4 questions. If you remember, I asked you 4 questions on the beginning. What was the question number 4? If someone can recall it. I told you 4 questions. We're gonna try to find the answer of it. What is the question number 4?
Cholinesterase recommended. Is
Thank you
cholinesterase
so
recommended for
much.
neuropathic disease?
My appreciation to your gray matter, Dr. Curran. Cholinesterase inhibitor. Cholinesterase inhibitors. Is it recommended here or no? I need you before you answer me to do the next. Raise your left hand from your lovely book to see the next line. Did you see it?
Yes, doctor. No evidence.
Not recommended.
So it's not recommended. And that's answers for you the question which we spoke about. So we had 4 questions. I believe that we did go through them now. Yes. We're gonna study more and dive more deeper. So okay. A patient is coming to your clinic. You did for him mocha, you find it abnormal. But he is independent. What it is?
Will we repeat it or?
Mild.
Mild.
No, it's
dementia.
not about repeated now, Dr. Andrew. It's about
A classification. Okay,
yeah,
mild.
yes, it's gonna be mild.
Correct.
So they either gonna give you it's independent, but the exam usually they won't mention for you it's independent because you're gonna find out the answer easily. They're gonna tell you that this guy is presented and they're gonna give you the daily living functioning activities. So activities of daily living, guys, and the instrumental activities of daily livings, please send them to the group now. Someone send it to the group now, please. So very important. So okay. The progression here is very important. The progression here is very important. They are saying for you here that they're gonna progress to major cognitive disorder, neurocognitive disorder, within 2 years. Yes. So there is a high risk to develop or to go to the major. Yes. So you can start as a minor or mild, and then you can maybe, if you're not treating, if you're not exercising, if whatever it is, you can develop to be a major. So very important. I think that we digested the mild now nicely. We're gonna go ahead and speak about the major. Yes. So major here is very important. So major. I need you to think about 4 things again. Please remember the 4 things now. Mainly that's what we're gonna try to find out from this topic. You need to think about what functional change defines the major neurocognitive disorder? What is the most important to rule out first before diagnosing dementia? What is the most common cause of dementia? What is the most common cause of a progressive dementia? Which dementia causes for you hallucinations and Parkinson, or Parkinsonism to be specific? Yes, we're gonna try to dive here for this topic to find out the answers for these questions. So please concentrate because someone can repeat the minor and the major, everything about it. Major. We said that you're gonna find major how, guys?
Independence. They'll be dependent.
So there will be no independency. So it's gonna be dependent. Yes, so it's a little yes. So no independency. So there's a significant cognitive decline with impairment in the daily or the activities of daily livings or the instrumental, both of them. Yes. So who is gonna just come to you and report this?
The caretaker
Family,
or the
family
family.
Caregiver,
or
yes. It could be the caregiver, or it could be the patient, maybe sometimes, or it could be just the caregiver. What else?
the
What you
partner.
get? Yes, it could be the wife, maybe. Yes, she's the one who's noticing it, because it's the caregiver. Yes. So you are looking to find out its major for 2 points here: a history and the independency. So you are looking for if there is a cognitive impairment, plus you are checking about the independency. How you are checking usually about the independency? You look for the history, or you are checking about the caregiver story. Yes, or the patient himself or herself. So they love it. They love to give you a patient is coming to your clinic. They play games here, presenting with confusion. Please, guys, close the mic if you can. Confusion, incontinence, and the next reason, fall. Once you see confusion, please think about delirium, dementia, major, minor, and so on. So when they give you continence or incontinence here, they are taking you to go ahead and check maybe about the bladder or whatever it is. But do not forget that it's a common presentation to find confusion, incontinence, and the last one falls. Both, or this is the hardest point to differentiate between the next thing or the next what we're going to speak about. Falls, once you see falls in elderly, you are jumping. Oh, I know it. I know it. It's orthostatic hypotension. It's good. Take it easy. Look nice. Is this patient is coming with a confusion? What age it is there is a declining in the daily activities or the daily living activities or the instrumental daily activities or no? Yes, make sure to check about this before you jump in and say it's orthostatic hypotension or whatever it is. Yes, check about this first. So they're gonna give you a patient, he's coming to you, problem with the medication management, problem with the finances, cooking, shopping. So even the falls, it could be caused because problem with the medication. Yes, maybe the patient because he's forgetting he's taking medication. Oh, I forgot to take it. I'm gonna take it. Oh, I forgot to take it. Oh, let's. They keep taking the medication. So yes, initially could be that it's the medication which caused for you the orthostatic hypotension or the fall here, or it could be that, or the main cause which you need to think about it is a major cognitive disorder, which made this patient forget that he is taking the medication or he took it already, and he keeps just taking more and more and more. So it could be you're gonna look for the functional declining. You're gonna go for the behavioral changes. What is the behavioral changes we are looking for here?
Personality changes. Aggression.
Agitation, psychosis, personality change, depression. What is gonna be a problem for you here or a red flag? You need to remember the red flags for your favorite major. Please concentrate because someone gonna repeat it all now. What is the red flags you need to remember? I need from you 3 points.
Rapid progressive.
Rapid progression. If it's rapidly progressed, what you gonna think about?
So
Suicide
it
ideation.
The Creutzfeldt.
Crucial Jacob,
Think,
that problem.
yeah, but first, if it's rapidly progression, think
Creutzfeldt
about
Jacob.
infection,
Yeah.
think about
Engineering.
autoimmune or prion.
Okay.
What else? If you find the patient he's coming to you with focal deficits, you're going to think about what is the two things you're going to think about in the focal?
Tumor.
Stroke.
So stroke or tumor. Stroke or tumor. So, and the other point, red flag, you need to look for it. It is delirium. Delirium, I won't take it much as a red flag, but I would take it under you cannot miss it when you are giving the diagnosis for the major cognitive disorder. Yes? If you come down here under the history, very important. So before, read this point for me, guys. Must. They didn't write for you should. Must. That's why I added it for you here under the red flags or you things which you cannot miss. Then they are geriatric giants. They are giving you confusion, which we spoke about. They give you the incontinence. They give you the falls. Memory and safety, they love to give it to you. Wandering, leaving doors unlocked, leaving the stove on, losing objectives, and driving. All of this point for the memory and safety. It's my favorite questions. And definitely you know the rest. I believe that everyone after what I told you, you know what you're going to do with this information. Dr. Isabel, tell me why this line is important.
Yes, doctor.
Yes,
Sorry,
tell me.
which line?
This one here.
Memory and safety, wandering, leaving doors.
Driving.
Yes.
Driving, locking the stove on.
Report.
Why the whole line is important, Dr. Stephanie?
Well, first of all, with the driving, we need to report. This is a reportable condition. And I mean, that's just telling us like it's a major cognitive decline and their safety is at risk.
Harm to self and others.
Exactly.
Because
It is important. Yes, it's important for you. Think about it, guys. Why I need to use this for my exam or how I'm going to use this for my exam. Because they're going to come down and ask you, counsel the patient, advise the patient. All of them could be advices.
Yeah.
Yes. A patient is coming to you, he is in a nursing home, he is 87, whatever it is, maybe end stage cancer, whatever it is. He is presenting to you with a complaint that he's wandering around. 87 from a nursing home. What are you going to do for this guy?
Just make sure they provide them a safe environment for them to work.
Yes.
Safe.
Provide them a safe environment to wander. He's already very old. What are you going to do here? Yes, you don't need to overload them with the medications or whatever it is. Yes. And the condition is not easy as well too. Yes. And this is one of the lovely questions.
Yes, this was a question I saw.
Okay, enough, Dr. Koran. Yeah. So please, a patient is coming to you and he is having a problem with the memory. Advise him. You can advise him about try or to close the doors or checking the doors, or you can advise the caregiver about this. Leaving the stoves on, you need to advise the caregiver to keep an eye and maybe to not let them to prepare food or whatever it is. Losing objectives, maybe. What else you could advise them? You can use the advices which is coming from seizures here as well too. What is the seizures advices?
No
Do not
swimming.
operate heavy material. Don't
Yeah.
swim.
Yes, do not operate
Don't use
heavy
sharp
material. I
objects.
would take it. Do not swim. A little hard to take it here. But the other one which I would take it is
I think keep the
remove
environment safe.
any sharp objectives around. Maybe remove the floor rags, which if you have any to
Yes.
prevent falls. Yes. So this is few advices coming from your seizures down to you here on your major. Yes. And you need to brainstorm about it. Yes. I need you guys while we are moving, you are brainstorming. Very important. Next, behavioral. So they're going to give you a mood and anxiety, psychosis, suicidal ideation, personality changes, aggression. Could be. We're going to take care of it later. So they're writing for you here. They wrote for you delirium. And because they were shy to repeat for you delirium again, they came here and they changed it for you word delirium to polypharmacy. So polypharmacy and compliance. Yes. So if the patient is coming with the behavioral findings, you need to see, is this patient, first of all, you have an elderly who's coming with a suicidal ideation, with a depression, with whatever they mentioned for you under behavioral here. What you need to do next, you need to go ahead and check about the medication compliance, especially if it's an elderly. Okay. So you need to rule out, first of all, if you have a major, you need to rule out. What you're going to rule out here? Any reversible cause. What is the reversible causes?
Infections.
So if you think about, I told you about the medication early, guys. They wrote for you here the anticholinergic and benzos. Yes? Heavy metal toxicity, there is one question coming from it. I'll show you the table. The table is up. Hepatic or renal failure, or you're speaking about the hepatic or uremic encephalopathy. You think about it, vitamin B12 deficiency, glucose, cortisol, whatever it is. Yes, they wrote for you here about thyroid dysfunction, hypothyroidism specifically. Yes, pseudodementia, they wrote it here for Dr. Stephanie. And they wrote about the tumors and the hematoma and the hypercalcemia even. You need to remember the reversible causes, guys. So investigation, you're gonna go ahead and do the same as what we did in minor. MOCA and or MMSE. Yes. So MOCA and MMSE. So you're gonna go ahead, rule out reversible causes. They love it. Yes. So step one, MOCA or MMC, because you need to check if there is a problem. Then you are ruling out your reversible causes: CBC, TSH, B12, electrolytes, glucose, calcium, LFTs, and renal function. Yes. then maybe you could go and do your HIV or VDRL or ANCA or sorry, ANA or rheumatoid factor or anything from what we spoke about. So it's almost the same thing, but we're going to speak about the management. What is the management here? Mm. Mm-hmm.
Maybe review medications first.
Okay.
There is also Beers criteria, I guess, for
Okay.
yeah, any unnecessary medication should not be used, should be eliminated from the list.
Mm-hmm.
Search for reversible causes.
Okay.
And then to reverse the ones you can reverse, especially with respect to deep prescription, reduce the quantity of dosing, as well as nutritional supplementation, vitamin B12, calcium. Any organic costs should be taken care of.
I need you to write down the next. A, B, C, D, E. What is the A, B, C, D, E, E? Sorry, D, E. One E. What it is? A. What is
Affective disorders.
affective disorders? What
Yes.
is the affective disorders? You are treating depression, you are treating maybe something else, you have found it here.
Yeah.
So you are treating the problems or the behavioral problems which you are finding or whatever it is. B.
Also ADL.
Behavioral problems.
B,
ADLs.
it's more concentrating on behavioral problems. A, it's affective disorders.
Also ADLs.
Okay.
There is written ADLs.
Okay. What else? What is C?
Caretaker cognitive
Yes.
stimulation.
Caregiver support. Very important. And the cognitive medications. What is the D?
Driving.
No. No. What is the D? What do you think is?
Directive.
Is the counseling, general counseling. For instance, those that need a space for wandering should provide a space for wandering. Those that should not drive should be restricted from driving. Those that need hearing aids, vision, and stuff like that should be assisted in order to help them to live an optimal life.
Mm-hmm.
Advanced directives should be this.
Thank you so much. Directives. Power of attorney or maybe assigning an SDM or advanced care planning. This is the D, directives. Last one, E. What is the E? What is the E?
Enhancement.
What is the E?
Enhancement.
Eyeglass.
Sensory eyeglass, earpiece.
Hearing aids.
So A,
Walking
it's
devices.
okay. E, it's gonna be environmental and sensory optimization. You're speaking about hearing aids, you're speaking about glasses, and so on. Yes, I'm gonna repeat them once more. Every one of you guys, you need to write it down. First of all, A, affective disorders. You are speaking about depression, you are speaking about an anxiety, you are speaking about apathy, maybe, or emotional lability. All these things is coming about are under your affective disorders. Yes, depression can look like dementia or make cognition more worse. That's why you are treating any disorders first. So next point, that's why depression is very important. That's why it was number A. 2, or number B, behavioral problems. What is the behavioral problems we are speaking about? Agitation, aggression, wandering, insomnia, hallucination, paranoia, anything, disinhibition, anything could be here. Yes. So so that's why you are looking for it. It's number B, and you are treating it. That's why you are looking if there is any other cause. Maybe there is a pain, there is infection, there is constipation, there is a urinary retention, there is a side effects, there is dehydration, and you treat this patient. Number C, caregiver support and cognitive medication. So here they love to ask about the caregiver a lot. They love to ask about the caregiver stress, how you're gonna manage it. A patient is coming to you and the caregiver, he's telling you that I'm so stressed. A caregiver, he's coming to you and he's telling you, I cannot stand to work anymore with this patient. How are you gonna manage this situation? A caregiver is coming to you and he's telling you that the patient tried to hit him with a glass or a cup just on his head. So safety issue at home. Yes. So a patient is coming with the caregiver. The patient is not or lacking. He's lacking enough support from his family. What you gonna do? So you're gonna go and look for the community support. Yes. So all these points, questions, you need to know about them. If you don't know about them, please start to search about them. You need to study, you need to look for the information. So, yeah, that was number C. D, what was D, guys? Directives.
Directives.
Power of attorney, maybe a personal directives, maybe SDM assignment, maybe, and so on. So you need to make sure that you are speaking about these things with the patient. Advanced care planning, maybe the patient is coming to you and he is worrying that something bad's going to happen to him. So maybe you can counsel him about the advanced care planning, or what is the steps you're going to do with him if he gets dementing or severely dementing in the future. Future living arrangement, you can help him to do any future future living arrangement, or you advise him to do it because you are not the one who's going to do it for him. Driving discussions, so you advise him to stop driving. Finances, maybe yes, maybe you ask him to get someone to assist him or to help him assist him or help him with the finances. All these here, or the points here, super important. All of them can be questions. Next. The E. What was the E, guys?
The E refers to
environmental. So it can be a patient who is coming.
Enhancements.
Yes. Patient is coming to you with environmental, or you're going to advise him about environmental. What you can advise him? If you don't find your hearing aids and glasses, what else?
Light, good light in the room.
Good light, what else?
The rocks.
Family member present.
Family, okay, family member present, that's, you prefer it if it's a delirium. Now you are speaking about a major.
No rugs.
No rags, yes. So you're gonna remove all the rags from the floor. What else?
Maybe handles or
Yeah. Near
Okay,
the toilet.
handles, yes. So sometimes when
And
they
the
are getting
bathtub.
older, they advise them to get, or to install handles on the stairs or
Anti-slip.
washroom.
the wash.
Anti-slip in the bathtub.
Yeah.
Something else.
Outside the bathtub.
No, something else.
Remove any sharp objects, cover the edges of the tables if they fall or something.
Okay, could be. What else?
I think the loose pieces of carpet or something. Like the
Yes, we
Rugs,
spoke about the rags. Yes, what else?
the Persian
You
rugs.
put
Done.
bright lights in the house.
What else?
Good lighting.
Good lighting, we spoke about. Guys, do not repeat something we said about. Give me something new.
Put some
Please.
music.
Something else. There's something else. Think more.
Is it about the bedding itself? Like it changed the
Give us a clue, Doctor.
environment. The temperature, maybe? Temperature.
Working is
So, yeah, walking aids could be.
Oh, okay.
So, hearing aid, walking aid to prevent, you are trying to prevent falls. Removing hazards, that's what we took from the seizures up here down. Maybe no one did mention about this. These guys usually you advise them to have as kids signs and labels at home to remember things. You advise them when you take your medication, make sure to write down before you take it. Because they forget that I took it, maybe.
Like
Yes.
a diary.
Yeah. And maybe write on the fridge, okay, that's this, or maybe write this, or keep with you something over your hand, maybe a band or whatever, that, okay, the stove is open, so you can look in your hand, you find, oh, the stove is open, I need to go and close it, and so on. So they help them with this way as well, too. Good lightning. No one did mention about calendars and clocks. Calendar and clocks. It's not
Yes.
only for delirium, but it could be here as well too. So the
Reorienting.
yes,
Yeah.
yes. So you can advise these guys to do something very important, a familiar routine. This means that, okay, you wake up in the morning, you are taking your breakfast, you are studying, then you are studying, then you are studying, then you are studying, then you don't sleep, then you study again.
Sounds
This is the
familiar.
yes, it sounds familiar for everyone. So yeah, that's your A, B, C, D, E, guys, what you need to remember for your exam. All the points which we spoke about coming under counseling, coming under what you're going to do here, and so on. And we spoke earlier about this sidebar, which is written here under your right hand. That's why you need to remove your right and left hand from the book to be able to see the information under your hand. Table 14 is important as the table which I showed it to you on the beginning. It's like a summarization for everything. Yes, please go through it. I have already attached a nicer copy just with things which I need you to remember from this table to your capsule. You need just to go and this could be your just quick revision table. Next. Let's go for the next. Life is hard with the QE1. If you don't want to remember the whole table, you cannot miss the first part. Just in case if someone is just thinking, okay, it's not important, I'm not going to do it. So, how hemochromatosis is present to you?
Sorry, what's the question?
Brown.
How
brown
Middle-aged
stain.
man.
Bronze diabetic.
Mm-hmm. What else?
Joint pains, liver
Joint
failure.
pains, nodules in the joints, nodules in the pinea.
Liver failure, like
Maybe
hepatic
deposition in the eye, but I'm not sure.
Okay. Hemochromatosis, please write it down. It's one of your homeworks for today. Everyone, you need to study it. You cannot walk to your exam if you don't know a single word about hemochromatosis. It's your bread and butter for this exam. So hemochromatosis, you need to write it down. So you have hemochromatosis, you have Wilson, you need to know them very nicely. Please, I'm gonna ask about it next time. So the table which is mentioned here for you is very important. How to differentiate between normal aging and signs or early signs of major neurocognitive disorder.
Normal agents, usually patients are aware of the situation and that they are forgetting just words or where did they leave the keys.
Sometimes they don't mention for you about the awareness or the patient knows or not know. But
no, but
look here. Yeah. Look to this, Dr. Stephanie. This one is going to forget names of the close relatives, maybe. This one, they can maybe forget something else or names of something maybe they are not using daily or whatever it is.
Words.
Yes.
Dr. Abdul,
Yes.
please, sorry to take you back to the ABCDEs of
Yes.
neurocognitive management. In B, what are the examples of interventions that can be used to address the behavioral problems?
So you are speaking about agitation, wandering, insomnia, hallucination, and so on, yes?
Maybe psychotics.
Yeah, so first of all, you need to start with, if this patient is coming to you, try to look for any other cause first, Dr. Henry, as we said. You need to exclude any other cause. Yes, so you need to exclude maybe if there is a cause of the pain, if there is infection, if there is a constipation, if there is a urinary retention, maybe if there is a medication side effects, yes, if there is a dehydration, if there is any unfamiliar maybe environment, they are moving somewhere else or whatever it is, no one is taking care of them or something is happening, then you can think about the management here. Your management here, it could be non-pharmacological as usual, yes, to try to correct if there is something you could correct it without medications. And then maybe you can advise them the next. Advise them to go for a calmer routine. Advise them to reduce the trigger if there is something is triggering this. Avoid them to advise them to avoid any restraints if it's possible as well too. But all these advices which you are gonna advise to this patient after you rule out any other condition or any other cause which you could treat. Did you get it, Dr. Henry?
Yes.
So, yeah. So, hemochromatosis, it's your homework. Yeah, normal aging and early signs of dementia. Please go through this sidebar here. It's very important. Because usually they sometimes giving you, if you don't know how to differentiate between normal aging, and you're gonna find questions in East Canada QBank about normal aging. So please study it good. Go through this sidebar. We're gonna jump in to go for your favorites. Alzheimer. Alzheimer, I won't spend long time just to discuss much here, but why it's happening in Downs? Because you are thinking about there is a 3 copies of the amyloid gene. Why you are thinking, or what is the things which you need to remember about Alzheimer? I need you to remember the 4 A's and a D. 4 A's, you have Alzheimer disease. 4 A's and 1 D. So you remember Alzheimer disease, you know what you're looking for. A, anterograde amnesia. A, aphasia. A, apraxia. A, agonesia. And the D, disturbance in the executive function. And you know now what is the executive function. What is aphasia? Let's go one by one.
Lack of speech.
It's a problem with words. It's not lack of speech only. It's a problem with the words. Apraxia. What is the apraxia? What is apraxia? What is apraxia?
Person's impaired ability to make the purposeful movements.
Purpose movement, yeah.
A problem with the motor skill.
Perform the learned skill and he forgot.
Problem with the motor skill, yeah.
Mm-hmm.
What is agonesia?
Agnosia, to
Yes.
recognize familiar objects or faces or
It's a problem with recognition.
Familiar objects, people.
Cannot recognize
Yes.
familiar.
Yes. So they wrote for you here about mild or moderate severe phase. They wrote for you about a typical non-amnetic presentation, which is the following three of them written for you down here. I won't spend long time here, but these things you could read it just quickly by yourself. The pathology or which is not specific for here, I won't spend long time. Maybe go and read your genetic factors. I will concentrate more on the investigation. What is the investigation you're going to do here?
We're going to start with the MOCA.
So MOCA, you could start with it, yes, because you are thinking about major or minor or whatever it is.
Yes.
But for Alzheimer's disease, when you find the 4 A's and the D, Dr. Stephanie, what you going to do?
We can do MRI.
So yes, very important. MRI, if you don't find MRI, they're gonna give you CT. That's why this table is very important because it's summarized table for everything you need. They wrote for you about investigation, they wrote for you what you're gonna find and so on. Yes, so it's like your revision table. So treatment, how are you gonna treat the patient here?
So we're
acetylcholinesterase
Sorry,
inhibitors.
so what is the drugs?
Dobenzil, memantine.
Donepezil.
So donepezil and
Memantine.
rivastigmine and
Galantamine.
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 Yes, remember the three drugs which is mentioned here first. Before you give this or any of these drugs, what you're gonna do?
Liver function test, maybe?
ECG.
ECG if you are starting specifically donepezil. Why? Because you are worrying about risk of
Heart block.
Heart block.
arrhythmia,
Arrhythmias.
arrhythmias and bradycardias. Yes. So it's not gonna just increase the prolonged life expectancy, but the treatment here is more to reduce the morbidities and to reduce the progression. Yes. So please remember it. It's very important. When you have MMSE less than 17, what you gonna do?
Memantine. Memantine will be the treatment for
Moderate to severe.
Okay. What do you think?
Or you give a combination.
Shall I exclude organic causes as well first?
In this point, once we reach to the specific treatment for Alzheimer, Dr. Andrew, this means that you did your MOCA before, you did
Okay.
exclude the other causes. Now you are treating Alzheimer.
Okay.
What are you going to think about? So we said that you're going to start with the donepezil or the rivastigmine or the galantamine. What else?
Like adjunctive treatment or alternative? What's the direction of the question?
Doctor, but like lesson 17, we will see like the management will be
Memantine, it's gonna
Memantine.
be the answer here.
Okay.
Yes.
Mhm.
So first drugs or the first anticholinergic or acetylcholinesterase inhibitors. Acetylcholinesterase inhibitors, that's what you're gonna think about: donepezil, rivastigmine, and galantamine. That's number one. So if you have a patient who is coming to you, what are you gonna do? What is the second line treatment? So if you have what they wrote for you here, MMSE less than 17, you're gonna go with the NMDA receptor antagonist, which is memantine.
Memantine.
Yes. So memantine, you're gonna use it. Very important. Um, I would leave for you to search about the side effects of each drug. I have already before added it to you to the capsule as usual, but I would leave it to you as well to search for it. Memantine is very important. You need to study it nicely. So next, is it only gonna just be a medication?
No, we need to give something not pharmacological, like
What is the not pharmacological?
occupational therapy or physical therapy, maybe something else to go with it.
Caregiver support.
So behavioral symptoms management. In Alzheimer, you have two ways here, ED. So you're gonna look for the 4A's and the 1D. What is the 4A's, guys, and the 1D?
Aphasia, apraxia, agnosia, and disturbance.
Yeah.
Okay. Okay, and you need to remember the meaning of each one of them. You have either it's pharmacological as usual or it is non-pharmacological. Pharmacological, you have two conditions here. You start with the cholinesterase inhibitors, but if you find, so it's acetylcholinesterase inhibitors, yes, or if you find your MMSE less than 17, what you gonna give?
Memantine.
Memantine. The
Memantine.
next thing under Alzheimer you need to think about is your non-pharmacological. Non-pharmacological, it's gonna take you to the point which we spoke about under your major cognitive treatment or the ABCDEs there. You could just look for any behavioral or psychological symptom management. So you're looking for agitation, aggression, depression, insomnia, psychosis, maybe treatment. And the first thing or you need to do here for this patient, if there is any trigger or something is causing the symptoms for this patient to worse, you need to remove it. If you have a caregiver, you're gonna do a caregiver education to prevent burnout, to prevent any stress, and so on, and to provide the adequate support to the patient. Maybe you're gonna just do the family support and the daycare, maybe programs. So yeah, do we do daycare program here?
Excuse me, Dr. Abdullah.
Yes.
A quick question. So earlier in the class, you said we should not use the cholinesterase
Cholinesterase inhibitors. Where, Dr. Kern? I said this and I showed it to you on in the book.
Minor.
Mild.
Wake up.
Mild.
Yeah.
Wake up. So,
Sorry.
okay. No, it's good. Okay. So the non-pharmacological treatment, it's mentioned for you here. Yes, and they wrote for you here about the daycare facilities, because I know someone, Doctor, daycare is for kids. Please, take it easy. Next, dementia of Lewy body. So what are you gonna look about here in dementia of lower body, guys?
Visual hallucinations.
I need you to remember here recurrent visual hallucination. If you have an elderly who's coming to you with a visual hallucinations, do not think just right away that's okay, I'm gonna go ahead and it's schizophrenia. Think about dementias. If you have an elderly is coming with a depression, do not jump, oh, it's a depression. Think about any neurocognitive disorder. Yes, so try to exclude this first. One of more of the Parkinsonism symptoms. So it's not only visual hallucination, but you can find a bradykinesia, wrist tremor, or rigidity. Yes. Plus the REM sleep behavior disorder. If you don't know about REM, please write it down and go search about it after the session. What I'm going to concentrate about here is, okay, you are seeing a 74-year-old man who presents with a 2 years history of a gradual worsening of a cognitive dysfunction and shuffling gait. His family reports a fluctuating periods. So with the fluctuating periods, with the confusion and attention, as well as uncharacteristic errors in calculation and spelling. His memory is generally preserved. Over the past 3 months, he has developed visual hallucination, and his family has noticed reduced the facial expressions. Recently, he has had brief episodes of talking and talking and falling during sleep. On examination, there is muscle rigidity in his torso and a shoveling gait, and the mini mental status examination score is 20. So they are telling you basically what is the most following diagnosis for this patient condition.
Lewy body.
Lewy body dementia.
Definitely low body.
Lewy body.
Yes, you're getting the major, or you're getting the symptoms of the neurocognitive, and you are thinking that, okay, there is a visual hallucination. Once they tell you visual hallucination, plus they are giving you Parkinsonism, you are thinking about,
Lewy body.
yes, especially they are telling you a sleep behavior disorder too.
Mhm.
So please remember it. That's the most common things, or that's the most important. They wrote for you major or minor, or mild or minor, because the mild or the minor it can start with and then it can progress to be a major. Yes, and you know now how you're gonna differentiate between if it's a minor or a mild or it's a major. So treatment, what is the treatment? Low body.
Only symptomatic
Is it common in males or females?
males.
So symptomatic.
Sorry,
Symptomatic
Fatima.
treatment available, but it's not everything. You need to remember that you're gonna go ahead and give the acetylcholinesterase here as well too.
Sorry, I have one confusion. Sometimes they ask like a patient have Parkinson like symptoms, and when they increase the dose of the Parkinson, and now the patient start with the dementia symptoms.
When they
So
increase what, Dr. Sajda?
the dose of Parkinson medication.
So when you say Parkinson medication, we spoke about memantine, we spoke about many medication. Which medication you're speaking about?
Like, I think I remember one question, like they not said specifically any medication. They said they just said after increasing the dose of the Parkinson medication, now patient is doing well with the Parkinson symptoms, but now the dementia symptoms are more prominent. So I think they ask like what kind of the dementia is this now? Is it a Lewy body dementia or Parkinson like dementia, something like that?
Mm-hmm.
But I think there are a few medications for Parkinson that can cause like like hallucinations and stuff like
Yes, that's the more commoner question that comes from that axis. A patient with features of Parkinsonism and is placed on Parkinson medications, and the patient begin to hallucinate with agitation and things like that, which is medication-induced psychosis, yes, as a result of activation of the D receptors.
The only two things here is the 1 year rule, which you can think about. 1 year rule, it's mean for you. If the dementia is happening after 1 year after the Parkinson motor symptoms, that's going to be a Parkinson disease dementia. If the patient is having or developing the dementia before or within 1 year of the Parkinsonism, there's going to be a dementia of Lewy body. You need to look into the question, what they are saying to, and find out what it is. So it's not only about that the patient, he took the medication and then is presenting with a dementia or dementia is worsening. Yes, you know that dementia, it's worsening. Dementia, it is progressive. But you cannot say it's okay, it's a Parkinson dementia or it is a Lewy body just like this without you find an extra information. Yes, so you need to look for the rest of the information or the rest of the question to be able to solve this one. So
can it be like before the dementia started, but the symptoms were not so much prominent, but after taking the Parkinson medication, now they became prominent?
I'm not sure, Dr. Sajda. If you can get me the question, maybe I can give you an idea, but because it's just a half question.
Yeah, I think that we are missing some information in the question.
Very important information.
Yeah.
I know that sometimes things in your memory, you are recalling it, maybe, yes. But if you have the full information, that's going to be maybe help more. Because
Timing is pretty important. Sorry, timing, as the doctor mentioned, timing is pretty important there. Like what is present first is like the motor or the dementia or which medication too. There are a few medications that can cause like hallucinations. So because I think that is a step down for when the patient is with Alzheimer's and they start having like side effects, like which medications we should like stop and.
No, the thing here is, are they asking you about the medication or they are asking you about the type of the dementia? Yes, because if you don't know what they are asking you about here, it's a big problem too. It's the same point at what I discussed with Dr. Easter just I guess yesterday when we had the ethical question and we were speaking about CAS or whatever it is. Yes, and she was saying something. Oh, I saw this question. Yes. So later on, when I was discussing with her, yes, just privately, about this again, she said to me, "Oh, this is the question I got." Okay, the question she got, it had a line which did tell her, "Okay, this is the correct answer which you were speaking about." But that question which we were discussing, it had another findings. So each question, one word can change for you the answer. They can put for you one word. Yes.
Okay, the page before this one,
Say again, please.
just go up. If you go up, the page before this one, if you just go up, yes, the last part, this suggestive or supportive features. No, not this. Not this.
You mean
If
here,
you go
this one?
when they talk about sensitive, yes. severe sensitivity to neuroleptic medications. Is it what she's talking about?
I think she's speaking about the levodopa.
Okay.
Yes,
I think she's talking about
Yes,
the
she's talking
levodopa.
about the levodopa. The levodopa-induced psychosis is
Yes.
one of the complications that have been seen in some vignettes, where the levodopa is stated and the patient start manifesting psychotic features, which is purely drug-induced. It's a different issue. But the one that Dr. Abdul is talking about is a rule of the thumb. You must find out which features started first. And there's this 1 year rule, which Dr. Abdul have mentioned. If Parkinsonism features are there 1 year before cognitive symptoms, then it is Parkinson's disease dementia. But if it is dementia, cognitive decline, and then 1 year after, motor symptoms now started manifesting, that is Parkinson's disease, the features started manifesting, then it is dementia with Lewy body. That one is a rule of thumb, and it's a purely duration that can distinguish each.
Yeah. So I think that's if dementia is worsening after increasing a drug, but they are not going to tell you, oh, it's a drug, because if they tell you it's Alzheimer drug, it's different than it's a Parkinson drug. Yes, because in a Parkinson, will you give the same drug as you give in Alzheimer?
No.
It's not.
No.
So it depends. Maybe they did mention in that question that it was a Parkinson. Yes, if they didn't mention it was a Parkinson there, then they are not testing you about the levodopa. Maybe they are testing you in general. So they either testing you about either it's a Lewy body or Parkinson, and you know now the difference between them. Either they asking you about the levodopa, and if you think about the levodopa, you're going to think about the medication-induced hallucination and confusion in Parkinson dementia.
And Pramipazole causes hallucinations too, and it's part of the
Yeah,
Parkinson
yeah.
management. So
Yes. So
Okay.
okay. They wrote for you a lovely line here, which is average duration of survival 5 to 7 years. Frontal lobe dementia. Yes. Is Lewy body a rapidly progressive dementia or no?
No.
Yes.
We
Yes.
studied
Yes,
Dr.
yes, we
Dr.
study.
Henry.
Oh,
Yes.
sorry.
Dr. Henry.
Sorry, I think I missed it.
When you are stuck.
there you
Yes.
go.
Okay, so I used to know that.
Do you see this, Dr. Henry?
Where, please show me again. Maybe I was not there when you guys started. I joined a few minutes ago.
Dr. Henry, please. Do you see
Yes,
this?
most common cause was rapidly progressing. Okay. That's okay. So I know frontotemporal. I know of Huntington's disease and Creutzfeldt-Jakob.
No, but Huntington disease, it's you can put Huntington disease under the early presenting.
Onset, yes.
Yes, early onset. It's
Okay,
different
but
than
not
the most
natural, not necessarily rapidly progressing. For
rapidly.
Huntington's.
Yes, rapidly. It's these guys here.
Okay, it's all right.
Yeah.
So DLB, CJD, and
yes,
frontotemporal.
you need to turn it to be a small sticky note in front of your eyes.
Thank you.
Okay. Okay, let me give a question so we can see who's awake and who's sleeping. Dr. Stephanie, please pick someone randomly from the group to see who is awake and who is here and who is just sleeping towards 15 years.
Okay. Dr. Dosey? Dr. Dosey.
You're saying juicy or?
Juicy.
No, sorry, what you are saying, Dr. Stephanie?
Dosey. Dosey. D-O.
Oh, Dosey. Okay. Dr. Dosey. I'm
Yeah.
just hungry. Sorry, guys. I'm just hungry, fasting.
yeah.
Yes. So I'm imagining everything food and drinks now.
Same here.
Yes. Yes.
Dr. Dosey, are you awake?
Okay, someone else. If the second person, Dr. Stephanie, gonna pick, he or she is not answering.
Irene.
Dr. Irene, please. Dr. Irene, please.
Don't try your luck.
I can take the question.
Who's this?
Dr. Munira.
Dr. Munira, I'm trying. Okay, I'm gonna give it to you if okay, let's see who's not answering.
We want to pass, doctor. That's why.
Yes. Okay. Okay, I'm gonna give it to okay. Let's take or give it to Dr. Munira. Okay, Dr. Munira. A 55-year-old dude is coming to your clinic by his wife, or he's brought to your clinic, sorry, by his wife. Because of a progressive behavioral changes over the past 18 months, he has become socially inappropriate, makes impulsive purchases, and frequently eats large amounts of food despite not being hungry. He has also become less empathetic and needs a prompting to complete a routine task. His memory for recent events is relatively preserved. What is the best next diagnosis?
Frontotemporal as a progressive behavioral change.
So will you pick Alzheimer? Will you pick frontotemporal? Will you pick a dementia with Lewy body, a major depressive disorder, a vascular dementia?
Frontotemporal as behave change within 18 months. If Alzheimer will be very slowly.
And you need to look for the 4 A's and D.
Yes.
Apraxia,
Yes.
agnosia.
Yes. Okay, please tell me anterior, so you forget the most important one.
Which is the number one? Yes.
Aphasia, sorry.
Cognitive
No,
decline.
not apathy.
Because in your question, the cognition is relatively preserved.
Yes.
Anterograde
That's why it's
amnesia.
Anterograde amnesia, yes. So here we are speaking about the frontotemporal. You're going to think for me about how we're going to differentiate this. Yes. So, or how we're going to find it? You're going to find this good guy here. When you find a personality changes. They love to ask about personality changes. Next question, who's going to take it?
Can I take it, doctor?
Okay, Dr. Stephen. So, okay. Dr. Stephanie, no, I'm not going to give you this question. I'm going to give you another one. How you differentiate between a frontotemporal dementia and a parietal or a posterior cortical pattern?
How do we differentiate frontotemporal?
Frontotemporal or a parietal posterior disease?
Okay, well, let's go start with what I know. So the frontotemporal, it's just going to start with behavioral changes,
Behavioral, personality,
personality,
yes,
impulsivity, yeah,
and language. So remember, please write 3 things here: behavior, personality, language. How about the parietal or the posterior disease? Or posterior or parietal dementia?
Could it be with no, that's a seizure. Maybe hearing. I'm trying to.
You're gonna think about, please write it down.
Okay.
P. So you're gonna think about the visuoseptal and the septal problems.
Sure.
What is the problems? You are thinking about patient, he or she is getting lost. They are having a problem to park their cars. They are having a problem to reach home. They have a problem to read the visuoseptal problems. We spoke about it on the beginning of the session. You remember?
Oh, yeah.
They have a problem, or they cannot copy shapes or the clocks. They have a problem, anything visually. They have a problem with the vision. So think about it that it's the posterior. If you think about it, if you have the brain just looking like this, if you have the frontal part is affected, definitely it's a personality and behavioral problem or maybe language.
Yeah.
If you have the posterior part is affected,
Memory, vision.
memory, vision. So I need you to remember vision and memory.
Mm-hmm.
Did you understand how you're going to differentiate between them?
Mm-hmm.
Frontal and the parietal.
Can you please repeat, Doctor?
Yes. If you think about someone got a problem in the frontal or the frontal area of the brain, frontotemporal, you're thinking about behavioral, you're thinking about personality changes. Even if the patient is without dementia, if they get a lesion there, they're going to present you with a behavioral and personality changes. If you got a patient who got a lesion or they get a problem on the posterior part of the brain, you're going to think about memory, you're going to think about vision. That's why when you hit someone on the back of the head, what's going to happen to him or her?
Loss of memory.
Loss of vision, loss of memory, and so on. Yes, loss of vision more as well too. Yes, so that's how you differentiate between the frontotemporal dementia and the parietal or the posterior disease or dementia. Did you get it, everyone?
It
So
was personality, behavior, and what was the third one? Sorry.
language.
Language.
Okay, thank you.
Yes.
Sorry, did you say it's the same as Pareto?
All the the past 10 minutes or 15 minutes, we made this question to differentiate between the frontotemporal and the parietal. Did you get the difference between them?
Yes, I did.
Yes. So what you
So you
wanted to
said
say?
posterior? I said the posterior
Posterior,
is
that's
this.
the parietal.
Okay, okay. I just wanted to clarify.
Yes,
Thank
yes,
you.
yes,
Yes.
yes. My appreciation to your gray matter. Vascular, just give it a quick look. I will give more attention to vascular dementia. Just give it a quick read. Creutzfeldt-Jakob disease. Where is the problem?
It can either be acquired or it could be hereditary.
Mm-hmm.
So that is I think in the way that some protein fall.
Mm-hmm.
So yeah, the prion protein had a problem with the folding and
Mm-hmm.
Also neural loss, maybe.
Okay.
And it's rapidly progressive as well.
Just give me 1 second. Let me make sure that we have a space for the recording. Otherwise, people who's missing the session now, they won't be able to listen to it.
Dr. Abdul, before we move into the
Jacob.
CJP, yes, I still want us to still elaborate a little more on frontotemporal, because when you get to frontotemporal, they try to divide it into several, as in other subtypes, and sometimes it's difficult to recognize. Yes, there are different subtypes that sometimes I'm not really conversant with it. I keep wondering how is they'll bring somebody that has maybe hypersexuality and they say this is frontotemporal. Another one is somebody that has apathy and empathy for others. Somebody that is hostile with emotional changes, still frontotemporal.
So if they give you a patient who became rude, impulsive, sexually inappropriate,
sometimes jump at another person's car.
They are buying different things. They lost the social awareness. They don't know if there is appropriate here to put on or take off the clothes. You are speaking about the behavioral variant, the same as the question which Dr. Munira got.
Okay.
That's how you remember it. Early personality and behavior change, disinhibition, apathy, or you have a loss of empathy here, poor judgment, convulsive, repetitive behavior, executive dysfunction, and memory. Maybe here problem. Yes. So in the behavioral variant, you can write down behavioral changes come first. Language, it's not the main thing here. The second one, primary progressive aphasia. They're gonna give you a patient who is coming to you, he is slow or he is presenting with a broken speech. The patient knows what she wants to say, but cannot put this into words. Or they describe it for you in ease as a telegraphic speech. This is your primary presentation. That's all what you need to remember. So if it's the behavior, it's the behavioral variant, and we spoke about how they are presenting it to you, Dr. Henry. If it's only the speech or they cannot put the speech together because you're thinking about the language, you're thinking about the primary progressive, yes? The second one. So the last one here, which you need to remember, it's the somatic variant. What is the somatic variant, guys? So they wrote for you here that the primary, that's when they have a problem with the speech. There is a 3 subtypes here. Non-fluent, the patient is not able to speak nicely or they are not able to speak as what we are doing right now. Maybe words, or they are trying to say the words, they are not able. Or somatic. What is somatic? So the non-fluent, that's what we spoke about. Speech problem, slow, broken. The lady knows what she wants, but she cannot describe it. Somatic variant. What is the somatic variant? Somatic variant here, Dr. Henry, because you're going to repeat all of them. Somatic variant, it's loss of the word meanings. Impaired naming. If you think about the non-fluent, they know the word, but they are not able to see it. Somatic, they forget or they don't know. They lost the, yes, they are not able to know what is the word meaning, or when you ask them to do this, they don't know what to do. Non-fluent, they know what is the meaning. Eat, they know how to eat, or what is the meaning of eat. In the somatic, they don't know, they forgot the meaning of the words. So they're gonna give you a patient who is speaking normally, but he is just using a vague words. A patient does not understand what does the common words mean. A patient cannot describe what is the object's name. A patient cannot respond to a simple word because he does not know what does it mean. Here you're going to think about which subtype? Somatic. Yes. So
Somatic doctor means comprehension is affected.
yes. Yes, with other words, comprehension, you can say it's yes. So it's word comprehension just a problem. It could be meaning, it could be naming. Yes. So next to somatic, you're gonna write naming, meaning. Non-fluent, you're gonna make a line and you're gonna write. What do you think you're gonna write? So maybe speech problem, Maybe it's a
Cursive.
grammar or sentence formation.
Slow,
They
yeah.
are not able to speak properly.
Really.
Yes. So that's the major things which you need to remember here. I think that now you can differentiate easily between the behavioral variant of the frontotemporal and the non-fluent argumental, and you can think about the somatic one. Did you get it, Dr. Henry?
Yes.
Please tell me how you differentiate between three of them.
Okay. Okay. So what is frontotemporal? They are divided into three. We have the first one is the behavioral variant.
Mm-hmm.
In the behavioral variant, these patients have early personality and behavioral changes. Okay.
Very nice. So if you ask if the behavior changed first, what is the variant you're gonna use?
Behavioral change, that is the behavioral
Behavioral.
variant.
Yes. If you ask if there is the speech is effortful or the speech is broken,
Then that is primary progressive frontotemporal dementia.
which subtype?
Primary progressive.
Yes, which
Primary
subtype?
progressive aphasia type.
Non-fluent.
Dr. Henry, look to the
Yes.
subtypes which is written to you here.
Okay, non-fluent. Yes,
Thank you so
non-fluent
much.
grammatical variant.
Yes.
Exactly.
If the speech fluent, but the patient has lost the word meaning or naming.
Yes, an understanding of meaning of words
So
and
that's
naming
gonna be,
objects. That's one. That would be somatic type.
yes, yes.
Somatic variant.
Somatic variant. Yeah, I think that's all what you need to know here.
Okay, thank you very much.
And what is the third subtype, Doctor?
Third one? No, we get three of them now, which we did concentrate on it. The behavioral, we get the non-fluent, and the last one, it was the somatic. There's the three things which we spoke about. If you mean the last subtype, it's written for you here. The logopenic. Yes, you can just give it a quick look if you want. I never seen it anywhere. If you want to give it a quick read, just give it a quick read. So, Kreutz Jacob, my favorite. Why this is my favorite? What do you think?
Exam favorite because
Because it's important.
It has the worst prognosis.
Fatal.
Exam
Yes.
variant.
Ask
Rapidly
yourself
fatal.
why it's exam favorite. I need from you the reason now, Dr. Munira.
also it's rapidly progressing.
Thank you so much.
Yes.
Because they need you to pick it up fast in your exam because it's a rapidly progressive dementia.
It's a death sentence.
Yes. So rapid dementia, yes. You can find the myoclonus, which is sudden jerking movements, ataxia. What is the best next step for you?
Symptomatic management of the seizure.
Yes, lumbar puncture.
Supportive.
So,
advanced care plan and all that.
So what is the etiology here? What do you think?
Protein from the helix.
Okay,
From
but
the
why
helix
it's
to-
happening? Why this happening to the protein or the prion protein?
It's as a result of infection.
So the most common
prion
type, it's spontaneously.
Yes.
85%, which is written for you here.
Destruction of the
second
neurons.
hereditary, and the last one, it's acquired. Yes?
Less than 1%.
Yes. Anyways, we are not going to speak about the prion proteins. Just remember it. They describe it for you here. They explained for you here. Clinical presentation is the one which you need to remember very nicely. A young patient is having a dementia progressing over weeks to months. What are you going to think about?
Rapidly progressing,
Rapid progressive.
week to month.
Yes, but what it is? What is your answer?
Creutzfeldt-Jakob.
Thank you so much. Think about CGD.
But they didn't mention the age of onset. Is it found in elderly, younger people?
No, but here you are thinking when we say the reasons or the most common causes of dementia, or rapidly progressive dementia, you are thinking about this guy is the first one you're gonna think about. Yes, and we had the list of the rest of them if you don't find it. What is the best investigation here?
CSF analysis.
We can do LP or we can do MRI.
MRI. Yes. So MRI, you're gonna find two signs. What is the two signs?
Ribbon.
The ribbon sign and the hockey stick.
Cortical, yes, ribbon and
Hockey
hockey stick
Hockey stick.
sign. Please remember both of them. They wrote for you about CSF. CSF, you're gonna find protein. You're gonna find the RT, yes. EEG. What you gonna find in the EEG? Periodic sharp wave complexes. It's written for you here. EEG, periodic complexes. Usually they don't concentrate much on the investigation because they know that once you find out it's a rapidly progressive, what you're gonna do?
Well, there is no treatment for this, just symptomatic.
So yes, it's very bad. It's very bad one.
Mm-hmm.
So we have to do the definitive diagnosis.
So you need to tell me the answer for the next question, Dr. Sajda. Dr.
Yes.
Sajda.
Yeah, I'm here. Yeah.
A 62-year-old man is brought to the emergency department because of a rapidly progressive memory loss and gait instability. Over 6 weeks, his wife reports a frequent sudden jerking movements of his arm and increasing difficulty of speaking. On examination, he is disoriented and has a multifocal myoclonus. Which of the following is the most likely diagnosis?
They have like motor symptoms, look like Parkinson, and then memory problems also. So, but like how long they have the symptoms? He have the symptoms. Sorry, I missed that part. 6.
If
6.
if I repeat it to you again, you're gonna find out the answer, Dr.
Oh,
Sajda.
sorry.
What is the answer, Dr. Stephanie?
I think that's it. CJD, no?
Thank you so much. So it's not only a young patient.
So, yeah,
It's a patient brought to emergency department because of a rapidly progressive memory loss. Once they write for you rapidly progressive memory loss, you are the happiest person in this world because you did join the session today. You did remember the most rapid or most common rapidly causes of dementia. You don't care as much here as or about the other things. You are thinking about CGD, you're thinking about the other causes, and you are thinking, is it rapidly yes or no? So, very important. What you are speaking about, it's not supposed to be called Parkinson. I need you to think about like Parkinsonism.
Oh, yeah.
Because when you say Parkinson disease, it's something else.
Yeah, Parkinson's.
If you say Parkinsonism, you can find it in most of the dementias.
The movements.
Yes, that's the type of the movements.
Even in the EPS, we have
Even you find it, yes, in your psychiatry chapter. So
So, Dr. Abdullah, here that was the distraction for CJD, the
it's
movement.
not like a distraction. Yes, it's not like it's a distraction. But look here, Dr. Sajda. You did forget about the myoclonus. They wrote for you about the impairment. They wrote maybe about the ataxia and so on. Visual changes can be so many things.
Oh,
Yes,
yeah.
you
Yeah.
are concentrating on rapidly.
Yes.
Yes,
that's what
they
I-
wrote for you what the whole group is presenting with.
Mhm.
Mutism. Yes, yes,
Once I
yes.
see the rapidly progressing,
Yes, that's a QE1 mutism, selective
The,
mutism.
sorry, visual changes will be the hallucinations or something else.
No, visual changes, it's different than hallucination.
But I think these patients get a visual hallucinations too,
This
no?
patient, so he was speaking or just, okay, sudden jerking movements in his arm,
That's
increasing
neoplan.
difficulty speaking. On examination, he is disoriented. There is a multifocal myoclonus, and they're asking you what is the diagnosis. They didn't speak about vision. I don't think that they spoke about vision.
Yeah. But here I see it like it's written mutism, weakness, visual changes.
Yeah, visually changes. It could be anything here, Dr. Sajda.
Like this dementia is like it progressed like in couple of months, like 2-3 months, like the
That's
patient
the
went
thing
so
about it.
quick.
Yes, yes. So, you won't think more about visual changes here as a specific sign for you to think about, okay, what's specific here? Because if I come to say for you, okay, it's a visual hallucination, what are you gonna do?
Can be so many things.
Yeah.
Yes. So, okay. Do you want to stop here, guys, and do the rest tomorrow?
No,
Is this a job, doctor, or
no.
If you wish to stop
Merci,
here,
doctor.
guys,
no.
if you wish to
No,
stop here,
no.
write yes on the chat, guys. Please, guys, take it easy. Write
Don't
yes on
stop.
the chat.
Don't write yes, please.
Please
Doctor,
write
tomorrow
yes.
will be fresh.
You cannot focus?
I want to finish before Eid.
Yes, we're gonna finish before iftar.
That will be
So,
the last iftar.
okay, I see.
How much is left, doctor? Like
We
for
need to be fresh.
I like to be fresh.
Yes, yeah, you will never be fresh. So you will never be fresh. Whenever you say fresh, next day you're gonna come and you're gonna have a
Worse.
headache.
I
Specifically, you're
wake
gonna
up
have headache.
worse.
Yes, you're gonna be present with a headache.
How much is left? Like for our target?
For my target for today, at least we need to have few more pages because all these things you can just go scan it by yourself. I believe that you have done the checklist. If you didn't do it, please go through it with the checklist. I will stop here one moment and then we're gonna go for Parkinson. So since we did stop here and I see Dr. Abir, you want to take a break. Come forward. I love to see new people, guys. They are falling on the traps.
Mm-hmm.
Yes, doctor, because I did all my patients with your lecture since 12 o'clock, and I have a headphone in the ear, and I just don't want to make sense.
No, that's totally okay. Anyways, I'll try to do for you or provide you with the recording. But let me just give you a gift here. Okay, let's see what his hair luck is gonna take here for today. Oh, very nice one. Okay, Dr. Abir, I'm gonna give you a chance to choose. Do you choose TN or the black box?
Oh my God.
Black box.
Okay.
Yay.
You have no mercy for the black box anymore, guys.
No.
Okay, let's go ahead and see what the black box is gonna get you. Yeah, once I open the black box myself, I get excited. Okay. Very lovely. Let's go ahead and do it. Do you want me to read it for you or you want to read it by yourself, Dr. Abir?
I'm sure I can read by myself, but I don't see it as a question.
Okay. I'm gonna give it to you. You can read it.
Okay.
Let me post it for you on the chat. Easy, simple one, because you are busy there. Please.
A 48-year-old physician hears an orthopedic surgeon telling a colleague in the hospital lounge that he plans to move a family friend ahead on the elective hip replacement waitlist despite the absence of clinical urgency. Several patients with greater functional limitations are currently waiting for surgery. Which one of the following is the most appropriate next step? So I'm getting options or just I have to tell something?
You tell me what you're gonna do.
So I will tell my, it's like a physician, so we have to tell the, what we call senior physicians or I don't know the name exactly, report the authorities. Yeah, because it's not legal that we are going to give advantage to those who doesn't need at the moment. So first we
Okay.
talk first response that we talk to the colleague first, I believe. If not, then we just tell the higher authorities.
Okay. Okay. So, Dr. Isabel, please.
Well, that's not, it's, well, what I will do is first, it's not okay to do that, okay? It's not ethical to do that. So first I will talk to the physician tell him that I don't agree with that. And if it doesn't work, maybe we can talk to the supervisor or the next person in charge. I don't know.
Dr. Curran.
Here, Doc.
What are you gonna do? You love easy questions, guys. You did ask for it. I could give you one from TN. You don't want to go for TN.
No, Doc, we want the black book.
We like the black books.
So, what do you think? Do you want
So
me to
Doc,
give you options, Dr. Curran?
please,
Okay.
please, Doc.
Okay. Let me give you the options.
My
Dr. Andrew, till I
lighthearted.
send the options, Dr. Andrew, what is your answer?
Very easy.
Dr. Andrew, wake up. Okay. I think he's not here.
Well, he's driving.
Yes, maybe he's driving. Okay. So, okay, Dr. Curran, I'm gonna give you. Dr. Abir, please, you're still here. Tell me. Dr. Sajda, you are writing option E without I give option.
Yes.
How did you know it's option E?
I was just guessing.
Yeah.
Okay, Dr. Abir, what is your answer?
A.
All what you were thinking about in your options.
To discuss the concern directly with the surgeon before taking the further action. No. Wait. Sorry.
Yes, Doc. So in Jamaica we say deaf ears give liar trouble.
Mm.
So what I would do, Doc,
Okay.
is I would confirm first because I could have misheard.
Mm.
So I would confirm first with the physician, telling him that those things are unethical, right? It is unethical to be moving someone at a higher priority or closer to the top of a surgery list because of close relations. So I'd first speak to him, tell him that is unethical. If I then realize that he goes on and do it, then that is when I would notify the chief surgeon or head of
Love it,
administration.
guys. Yes, I love to see A. Dr. Henry Wando, what is your answer?
Triple A.
Sounds wrong.
Hmm. Okay, I'm gonna leave for you this question to
Oh,
Dr.
Then
No,
sure
Doc.
that he will do that,
Please
or I
be
just heard in the
a last
hallway.
answer.
Hmm. So your question here is a 48-year-old physician here's an orthopedic surgeon telling a colleague in the hospital lounge that he plans to move a family friend ahead on the elective hip replacement wait list, despite the absence of a clinical urgency. Several patients with a greater functional limitation are currently waiting for the surgery. Which one of the next is the best next step for you? I have wished to give you a question from the book.
no, we're fine, doctor. We love it.
Tell me, what is the answer? What do you think? What is the answer?
Doctor, I think this question come on their communication and professionalism.
It's
Yeah.
not communication here, but it's more as professionalism.
Professionalism, yeah.
What is your answer, Dr. Andrew? I have been looking for you.
I see the hunt. So, logically, I'll do the exclusion method with you.
Mm-hmm.
Let's start with option B. I heard the conversation in the hallway. I didn't clarify in person. I didn't talk with him at any occasion. I'll go on my own and report through the hospital. What if I'm wrong or I didn't get the complete picture? So I'll be doomed. Let's tackle option C. Notify the medical regulatory authority immediately. Again, lack of evidence, lack of clarification, lack of discussion, lack of everything. Option D. Inform the affected patient. That's gossiping. That's not right. Take no action. Option E. Take no action unless there is written proof that booking that might delay a harm. If this happens, that will cause harm to the patient. So again, so out of these options, A seems more reasonable, logical. You're approaching a colleague, you're discussing with him, you are putting your hypothesis. He's gonna defend the question or deny or insist. Then you will move with the report or tell the patient, whatever you will do. That's my analysis.
Doctor, we can see you, we can hear you. Please close your mic and camera. Oh my God, guys. Dr. Bix, please, guys, give me Bix triad and Bix cognitive triad, since we have Dr. Bix here.
Bextria is like DVD, muffled sounds, and
And where you find it?
Cardiac tamponade.
Okay.
The other one is
So,
negative thinking about everything.
and
yes,
depression.
future, life, and so on. Okay. What is the answer for the question, guys? All the group is going for
If it's not A, then no answer. All of them is wrong.
The whole group is going for a circle time.
A, I think.
Guys, never change your answer.
Oh my God. Here you need to change your answer, Dr. Stephens. Here you need to change your answer. Okay, guys, I'm gonna leave for you this question to search about it, and let's go ahead. I'm gonna give you another one. Oh my God, guys, life is hard. I need you to search about it so you can remember it. Whoever is gonna search about it, you're gonna remember a very high yield question, a very important question. Whoever is gonna waste time and he or she they won't look for the question, you won't be able to memorize it or understand it. So, okay.
Doctor, this is like those free trials that you get, and then you answer all the questions, and then you go at the end, and they say, "Okay."
Look for the
Yeah.
answer. Yes. 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 Okay. Doctor,
Now I will go with B. Sorry, I changed my answer.
oh my God. Why you change your answer, Dr. Sajda?
Because they said like how we do the with the child abuse. So they said even if you're not sure, but still you have to report it. So then this is their duty to investigate it and find the
But you are
proof.
speaking about child abuse?
No, I will just give you one option. So
Oh,
here I think the same thing will happen. You have to report it, and that will be that hospital's
but this
responsibility.
is different, totally different from child abuse. I don't
Yeah,
think
there
this
are
is just an.
certain things that we are gonna report right away.
Now
Other
you,
things,
yeah, someone just came to you. So when you are sitting and enjoying your dish, you make sure that you close your door. Because if you don't close your door, you're gonna either find the nurse coming to you, or another colleague is coming to you, or a patient coming to you. So please keep your door closed. This is the takeaway message. So, okay.
Dr. Abdullah.
Yes, Dr. Dimitra.
Yeah. This question seems like a very trivial, really like a mild thing, but I think at many levels there are ethical issues are being kind of breached. Like I don't like to take it like a very like a small thing that I'm going to discuss with the doctor because he's many levels like a justice wise, like he's doing so much of injustice to the person who's higher in the list. And obviously if there are any emergency situation with those patients at the top of the list, you are unnecessarily causing harm. So again, we can say argue we are doing the harm in we are breaching the non-malfeasance too, right? And the other thing, the whole process is really unprofessional, right? So because this kind of behavior, it's not limited to one breach of one principle, so many principles. So then again, so it's a breach of trust. So it's
What do you
not a
say you
simple.
want?
Yeah, I think we have to.
You don't leave me because I did they hungry like this. What
Doctor,
you
okay, Dr. Christopher, please go ahead. Dr. Curran.
Yes, Doc, I'm here.
Look to the question again and tell me what is your answer. And guys, if you want to know the answer, write yes on the chat now. Please write yes. If I find everyone is writing yes, this means that everyone awake, then we're going to have the answer. Please write yes. Please write yes. Let's see how many awake here.
Sorry, where is the question?
It's in the chat.
On the Zoom chat.
I
Wake up.
blinked.
It's the same question, right? Doc? 47,
Yes,
40.
it's the same one.
No, I've not actually seen the question.
It's on the Zoom, Dr. Henry. Zoom chat.
Okay, it's all right. I will check it out.
Yeah. Search for it, Dr. Henry, and find it. Please
Yeah,
write
you have
yes
to
on.
scroll way above because so many yeses are there.
So, Yeah, I decided to concentrate for you about more things, guys. I have surprises is coming for you soon. So be ready for the surprises which is coming for you. Definitely it's for people who's working hard. I see only 35 doctors they are writing yes. Where is the rest? Where is the rest of the 35? 75. Oh my
So,
God, guys.
yeah. So the other thing, Dr. Abdullah, now the guy is, breaking the
Mm-hmm.
policy of the organization as well, right? So
Yes.
there could be an internal investigation about his conduct. So this is nothing simple. Yeah,
So,
that's my.
okay. Yes. Thank you so much, Dr. Dimitri. Yes. It's a good, nice point, logical point. Very nice. What I need you to think about here is, Dr. Curran,
Yes, sir.
what is your final answer?
In light of previous discussion, probably go with B.
Thank you so much, Dr. Curran. This question here, the issue or the key issue, Dr. Stephanie, find for me the key issue. What is the problem?
Professionalism is
Dr.
And that
Stephanie.
was, yeah, I think it's
What
a,
is the problem? Tell me
Yes.
what is the problem? The main problem. Give me one
so
problem.
that you said the justice is
justice.
suspended
Yeah,
here.
Thank you so
Yeah,
much.
Yeah.
the public
So,
trust. Yeah, the public
so
trust for the profession, Dr. Abdullah.
fairness. You're speaking
Yeah.
about the fairness and the
Yes.
appropriate. So
Yeah.
you are speaking here about the key problem. It's not just that this surgeon said something inappropriate, but the key issue for you here, he is planning inappropriately to alter the access to the care for the personal connection. So that's a patient's safety and fairness concern. Yes, because you have more people, they are in critical or they need it more. So that's why your best option here is gonna be to report. Report the concern. Why? Because you are thinking about misconduct, which is happening here. You are protecting the integrity just of the waiting list, and it allows the documentation and investigation. Yes, they didn't tell you it's your surgeon or it's your whatever it is, yes, about anything like this, but they are mentioning you that um, the guy did listen to them speaking about it. So it's not gonna be appropriate to informally handle this. What does this mean for you? This, they are asking you, or this question here, best next step. Yes. If you go with A, discussing it directly with the surgeon,
He might deny and project it on me.
or you can go for this option, Dr. Andrew, if it's something minor.
Gotcha.
But here it's a conduct. You are thinking about, or the conduct is described here in your vignette, deliberates the plan to give, yeah, referral, or you are giving a patient who is not deserving, or maybe the patient who's not supposed to be the priority of this list, the treatment. Maybe you have someone in an urgent condition and they have been waiting for this for a long time. So it's fairness. Yes,
Unethical conduct.
yes. When your option, which everyone did choose, that's why everyone happily for a long time we didn't go for it, went for a circle time, it's gonna be your right answer. If you don't know, or if it's unclear, you don't know maybe what's happening, maybe you could go ahead and discuss with the doctor. Maybe if there is no evidence, or no one did listen to them, yes. Maybe if there is no immediate patient safety risk, Anything which has no or nothing to do with the patient safety risk, you could go ahead and speak about it. Maybe you are a patient, or you have a physician who's using maybe poor wording with the patients, and the nurse did listen. Maybe you're going to speak with him about that. Yes. Maybe there is a misunderstanding happened between the patient and a physician. Maybe you're going to go and speak with him first. Yes. So you need to make sure that you are reporting when it's something serious. When the misconduct is credible and serious, you need to make sure that you are reporting. Very important. If there is anything affecting or is just reflecting the fair access to the care or patient safety, you need to report as well too.
We are reporting, right?
Unfortunately, yes, Dr. Sajda. Dr. Sajda, after all the explanation which you said, if you don't know the answer yet, it's a big problem.
No, sir, I picked that one, so that's why I was just making sure.
No, explain for me why it's the right answer, Dr. Sajda.
Yeah, because that's elective surgery, and then you have enough time to, like, if you bring your concerns to the hospital, so at least they can find out before it happens.
Mm-hmm.
Right? Like follow all the steps, like it's like professionalism, malfeasance, and these all they can follow before it happens.
So I have another question.
Black box?
No, something, just 1 second.
Yes, sir. Give us another black box question.
So a 48-year-old physician, please concentrate here, overhears an orthopedic surgeon tell a colleague that he is thinking of helping out a family friend by moving her elective hip replacement. So it's elective hip replacement earlier on the wait list. The physician does not know whether any booking change has been occurred or no. No patient is at immediate risk. What is the best next step for you?
Same options?
Same options.
Okay, I think report.
I think now we can talk with the colleague because there is no patient risk.
So they did mention for you there is no patient risk. If they don't put for you there is no patient risk line, yes, and if they didn't put it for you, then you're gonna go for a report. If they add for you exactly there is no risk, there is no patient at risk, then they need you to speak with your colleague. Although it's exactly, or maybe it's close, yes, things, yes, or the close questions. But the other one, they did describe for you that there is a several patients with a greater function limitation and currently waiting there. They didn't describe for you in the first vignette about anything about if it's safe or not safe or so on. Yes, here the concern about it's not confirmed yet. It's not immediate harm yet. Yes, because they are saying for you no patient at immediate risk. So you need to read. It could be the exact question, but you need to see if there is a patient here at risk or no. Both answers could be correct. Did you get the second point, guys? So
Yes.
yeah, because they mentioned for you no patient at immediate risk.
Yes. No patient risk. Talk with colleague if they don't write or write several patient waiting in line. So report.
Yes, that's right. So very important. Okay. Ah, life is hard.
Dr. Abdullah, do we have to document this?
The problem here is you're gonna report, but where are you gonna document this? The problem is it didn't happen yet to make it as an incident report.
Yeah, but are we not supposed to treat this as a some
Yes,
incident
but
happened,
I'm
but the
just trying.
harm didn't
Yes,
reach the patient, right?
but I'm
So
trying to I'm trying to think how you're gonna document this.
yeah, practically speaking, yes. So,
Mm-hmm.
I don't know, when you have whatever you speak to with this orthopedic surgeon
Mm-hmm.
later to document somewhere, right?
Dr.
I don't
Burr, I
know.
think the report will be itself a documentation of the event and the discussion given. So you might
Yes.
need to provide a report to whoever you are reporting. I mean, sorry, a documentation of the
Yeah,
who you are
document doesn't
reporting.
necessarily mean reporting. Document, you can make your own note.
You
But
can you can go, yeah,
where
you
who
can
will
go
make
ahead.
that? But
No,
where?
but you can go ahead and document, Dr. Dinidri, as you're correct, because CMPA love to see you documenting things.
Yeah, yeah,
But I was just
because
thinking with you how you're gonna document it. Yes, I'm just trying to think about it because I didn't think about this before. How you gonna document this? Maybe we need to search about it. Yeah, I can search about it too. Yes, thank you so much,
yeah,
Dr.
like sometimes, Dr. Abdul, like some of the things, you have to have a personal log of events too, right? So
Mm-hmm.
in case, something happens in the future, I don't
Mm-hmm.
know. So
So I think that you need to report. So report and document. But document how you're gonna document. I need to double check about this. Yeah. Okay. Uh. Okay. Let's take a quick question here. Who's gonna take the next question, guys?
I want to take it.
Okay. I'll send it in the group. Um.
A 62-year-old man comes to your clinic because of worsening involuntary movement of both arms over the past 7 months. He reports that his father had a similar condition that was managed with medication. On examination, he has a low amplitude tremor in both arms when they are outstretched, which becomes more pronounced when he attempts to drink a glass of water. Muscle strength and tone are normal bilaterally. Which of the following is the most appropriate next step in management? So, low amplitude tremor in both arms. It's a flapping tremor when they are outstretched.
Mm-hmm.
And
So when they give you a low amplitude, bilaterally tremors, which is worsening with a voluntary movement, you're speaking about worsening with a drinking, maybe a glass of water, whatever it is. What are you gonna think about here?
with a glass of water, it's intention tremor. Yes.
What do you think?
But we do have family history as well, doctor.
Essential tremor because of the family history?
Mm-hmm.
Propranolol, the next step in management.
Okay, what do you think?
Dr. That's was an essential tremor.
Okay. So the question here, it's a 62-year-old man. He's coming to your clinic because of a worsening of involuntary movement of both arms over the past 7 months. He reports that his father had a similar condition that was managed with a medication. On examination, he has a low amplitude tremor in both arms when they are outstretched, which becomes more pronounced. When the patient is attempting to drink or he's having a glass of water, the muscle strength and tone are normal bilaterally. So they are asking you what is the most or which one of the following is the most appropriate next step. You need to find out the diagnosis. Your diagnosis is written in front of your eyes.
Essential tremor because it occurs during an action or movement, and it is in both sides.
Mm-hmm.
So it could be essential tremor.
It's an action posture tremor, yes. Essential tremor, it's written for you down here as well too. But it's one of your differential diagnoses. How are you going to differentiate between essential tremor and action posture tremor?
Essential tremor is symmetrical, but it can be like while resting.
Mm-hmm.
And then action, it get worse once that the patient like either write or hold out a glass or does something with their hands.
Okay. What do you think is? The question which we spoke about, is it an action posture tremor or it is an essential tremor?
Essential tremor, sorry, because they said there is a family history also.
I think it's an action postural tremor.
Mm-hmm.
Sorry, the essential tremor is the action postural tremor?
What is your answer? What do you think, Dr. Sajda? What is your answer?
I'm thinking about action postural tremor because it's showing like there's a family history and it's autosomal dominant.
Okay.
Yes, action postural tumor, family history there.
The question which we have, do you think is it essential or it's an action posture?
Action postural tremor.
Posture.
It's essential tremor. Why?
Because it occurs during an action or movement, and is in both sides, isn't it?
Because it's bilateral arm tremor, because it's happening when the outstretch of the arms, yes, and it's worsening when you have an action or drinking. Posture tremor, it's happening when you are trying to maintain the posture from the name of it. Again,
Okay.
posture, it's when the patient is trying to maintain posture they're gonna give you a tremor. Yes? You can just think about it because it's a little confusing and it's gonna keep confusing. Essential tremor, it's a diagnosis that typically can cause a posture and kinetic action tremor. And it's running in the families. Yes? So worsening with the drinking, no rigidity, no bradykinesia. So sometimes it's very hard. What is the treatment for each of them?
Like first we figure out the underlying cause, and
There
then
is no, it's essential, Dr. Sajda. What is the treatment?
like if we start with the propranolol,
Propranolol. If you don't find propranolol,
then for the sorry, for the like topiramate.
what is the name of what is the name of the drug?
If it is like with the alcohol withdrawal, so
You're gonna give the pyro, or sorry, the pyrimidone.
sorry,
What is the pyrimidone, guys? It's anticonvulsant.
pyrimidone.
Yes. So please remember the propranolol, sorry, and the pyrimidone. Both of them, you need to remember them. So if you have a tremor with an arm outstretched and worsening with action, family history, think about essential tremor. Even if you are confusing essential with the action and posture, because in action, the action posture they wrote for you here, it's worsening sustained posture. Yes. So please think about it. If the patient is trying to keep the posture, you're going to think about
Postural tremor.
Action posture tremor.
So if you have a patient who is just is coming with bilateral arm tremor, outstretched arm, patient he's coming to worsening when he is holding the drinks and so on, you're going to think more about the essential. So the problem here is or what's confusing you here is essential tremor can be the bigger word. Under essential tremor, you can find a posture tremor. Did you get it, guys?
So
Under essential tremor, you can get a posture tremor. Because this question is just got so many things under it. You have a patient with a bilateral arm tremor. You have a patient who is coming to you with outstretched arms that was falling under your action posture tremor. You have a patient who is worsening when he's trying to drink water, so you're thinking about action or kinetic tremor. You have a patient with a family history, so you are thinking about
Essential tremor.
So just to understand this, please concentrate on this point. Essential tremor, it is two things. Action tremor syndrome. Action tremor syndrome, you are speaking about 2 points. Posture and kinetic. So the action, posture, kinetic. What does this mean? This means for you that the point which they described for you at the patient is outstretching the hand, it's a posture tremor. Very nice, it's correct. But the point when it's worsening, when the patient trying to drink, you are thinking about action or kinetic tremor. If you find both of them, you are thinking more in a favor of essential tremor. And the best management for the essential tremor, it is propranolol. Come on, guys, wake up.
Propranolol and pyrimidone.
Yes. Parkinson disease. Parkinson disease. What is Parkinson disease? Why it's happening and why we see it?
And dopamine deficiency.
Mm-hmm.
And then is it like mostly the people who get exposed to the organic, the toxins like pesticides and farmers, yeah.
So Parkinson disease, you're gonna think about the neurodegenerative disorder due to dopamine loss in the substantia nigra. So they love to ask about the substantia nigra. They love to ask about the dopamine, yes. And what is the trap? Yeah, they love to ask about the trap.
Tremor, resting tremor, rigidity, cogwheel rigidity, akinesia or bradykinesia, and postural instability.
Very nice. They love to ask about the tremor. They ask which tremor it is.
Resting.
Resting or what? What
Roll
is the other?
beading, roll bead
Peel
Pen
rolling.
rolling.
Pen rolling,
Pen
something rolling.
Yes. Rigidity. What is the rigidity?
Cogwheel.
Cogwheel. Cogwheel. So akinesia, yes, or bradykinesia, and posture instability. So it's a very common. It's the second common reason after Alzheimer, and you need to think about the age. So pin rolling tremor, and they love to ask about the cogwheel rigidity. What is the other rigidity?
Led by
No.
Like with the Parkinson, there is cogwheel and
So one second. You said led by 5 years, guess?
no, I got it mistaken. No lead pipe in this one. That's spasticity, other stuff.
No. It's correct, Dr. Andrew.
Oh, I doubted myself.
No, it's correct. It's correct. Let me try to see where it is here. Because here they wrote about the cogwheel rigidity, and you can find the lead pipe as well to rigidity here. Bradykinesia, pen rolling. Where is the pen rolling? Pen rolling tremor, it's written here. Yeah. Next. Bradykinesia, slow movement, and so on. What you need to remember here?
Reduced facial expression.
Okay. So remember the trap. Remember the risk factors. It's a male, it's an elderly, yes. Pesticides exposure, rural living, yes, and head trauma. and genetics. So what is your investigations here?
Thyroid functions first. Could be.
Do you need to do any investigation here?
I think it's
a clinical diagnosis.
I think it's clinical.
It's a clinical, and usually you are doing or you are checking about the response to the levodopa. Yes.
Same as asthma.
Yeah. So what is the main first line or the first line drug here you're gonna give?
Levodopa.
Levodopa, carbidopa.
Levodopa, carbidopa, yes. And if you don't find them,
dopamine.
DMT.
no, they give you levodopa, carbidopa, or the levodopa.
Mau.
Levodopa
Benzazide.
under your left hand as usual. If it's a typical atypical Parkinson, they're telling you look for something else. How are you gonna find out it's atypical? When you find out it's a rapidly progressive, you're gonna think about maybe the rapid causes. If you think about a poor response to levodopa, maybe it's not gonna be your Parkinson. You look for something else. Early fall, so you need to remember all of them. All of them important. So, okay. So, yeah, they wrote you here about the early management of Parkinson's disease. It could be levodopa or dopamine agonist, and MAUS they wrote it for you, and amantadine as well too. Psychiatric, they are writing for you here about TCA, and they love to ask you down about TCA because they're gonna come down and ask you about the fall risk, about the cognitive impairment, or they can ask you about worsening of the symptoms of Parkinson's disease. So if you are giving TCA, you need to be aware about all these things. The next, very important for your exam. It was one of your homeworks, but let's do it together just quickly. Huntington's disease. What's happening in Huntington's disease?
CAG is repeated in HTT gene.
Yes, CAG. Yes, so you need to remember CAG repeated in HTT on the chromosome number
4.
Please remember which number of the chromosome here because they love to ask about it. You are thinking about atrophy, which is happening in the brain parenchyma. Yes. And what is the age here? Less than. It's gonna be young.
Middle age.
Young.
It's yes, young. They wrote for you 35 to 44 here. So
And it's also familial, right?
it can all of them can happen in genetically or because of familial causes. But if you think about it here, they are not writing for you even here about a common. They wrote you only about genetic, yes. But they didn't write you a very clear lines about what is the reason why it's happening, or why the mutation, or why the change, the gag, which is happening on the HTT chromosome 4 is happening here. They didn't give you much information about it. I don't think that they know yet exactly something, but that's what they are speaking about, that there is a genetic autosomal dominant.
Yeah. But sometimes in ethical questions, they said if the patient diagnosed, so are you disclosing this to the brother or sister or someone, right?
they can ask you about this though.
Yeah.
So it can fall about the disclosure, yes, but if it's genetical, you will encourage, you will do all what you can do, yes, but you won't do it by yourself. Do not go and let the family know by yourself. So yeah, you're gonna find they love to give you in this condition chorea. Major neurocognitive disorder, and they love to give you chorea here. Yes, they love to give you the next line, which is written to you down here. A progressive dance-like orbalism. Yes, and if it's a juvenile onset, you need to remember this one because it got a question in it. It's gonna be a Parkinson, dystonia, rigidity, seizure. You think about Huntington. What is the diagnostic test?
MRI.
Genetic
Is
test.
MI your diagnostic for genetic test, Dr. Sajda?
Sorry. Sorry.
Genetic testing, CAG.
Yeah, yes, they are writing for you
CAG
here.
repeat.
Yes, genetic testing, yes. Genetic testing. Definitely on the MRI, you can find some changes, but you want to confirm what is the diagnostic. A patient is presenting to you with progressive memory loss, and he is moving his eyebrows and forehead, and he started to develop a shrugging or shrugging shoulders. MRI is showing you enlarged ventricles and atrophy of the cerebral cortex. What is the answer?
Huntington.
Huntington. After they give you this presentation, they ask you the next. How are you going to confirm it?
Genetic.
The genetic.
Sorry.
Yes. So they come on the first, they give you the MRI findings. That's why you need exactly to remember it. And because you are suspecting it's on Huntington disease, you're going to go ahead and think about, I'm going to go ahead and do my genetic testing. If there is a treatment here.
No cure.
You're going to treat the
We just
symptoms.
treat the symptoms.
You're going to treat the symptoms. A 46-year-old female, her sister was recently diagnosed with a breast cancer. She's asking you for a referral for a genetic testing for BRCA1 and 2. What will you do, Dr. Curran?
I was writing, Doc. What was the question? Somebody 41 years old comes for
45-year-old female, her sister was recently diagnosed with a breast cancer. She's asking you to refer to genetic testing, her to genetic testing. What will you do?
I will refer and do mammography as well.
no. BRCA1. I would counsel her, tell her that BRCA1 is not used for screening. If you would like, we can do a mammogram, which can start at 40 to 49. I would explain the possible disadvantages of having of doing the exposure to
But she's high risk
radiation
now.
and whatever.
She's high risk
So
now. High risk.
we can do the mammogram now, but not BRCA.
Which is if it's high risk.
40 to 49. You can
Even in
start
high
that.
risk population.
No, but her sister does not. We don't know if her sister has the BRCA1 gene. So that's what I'm.
What do you think?
We can do the BRCA1 and BRCA2.
I think when we have a family history about male breast cancer or young age or ovarian breast cancer, see like that, we have to do it first.
The sister can get the BRCA loan too.
What do you think?
I think start with
Parker is not
the
a screening test, and she's not presenting any symptoms right now.
family history plus like start with the mammogram, the first step, and then I think we go with the
Would you go ahead and test this lady first, or you need to test her sister first?
sister first.
Her sister first.
So what you're gonna do here? First of all, you could go ahead and maybe take a detailed family history or hereditary history, yes, and you could maybe refer her for mammo. Yes. If you find everything is positive, very high risk, and mammo is coming to you, you are concerning about her, maybe then you could offer the BARCA testing. Yes. But do you test this lady first or you test her sister first?
Her sister. Her sister. We need to test the sister first.
So we don't just refer right away to BARCA like this.
No.
You need to do your assessment first, but you still can refer this lady who's coming to you to MAMA. Yes?
How was she? Again, sorry. How was this patient?
It's 46.
46.
So we are referring her to mammo, but not for genetic testing.
What is the indication to refer for BARCA?
Positive family history.
Male with breast cancer in the family.
Is it young onset cancer, relative diagnosis with breast cancer
breast
before
cancer
50?
before less than 50 age and family history of breast cancer. That's number one.
And then some like I think Ashkenazi Jews they have.
Before we go for Ashkenazi, we're gonna think about the multiple breast cancer in the family. So first of all, it's a breast cancer with the age and family history. Number two, it's a multiple breast cancer in the family. Number three, it is
involvement of the
ovarian cancer in a family.
Ovarian cancer.
Yeah.
Or
Yes.
it can also be a combination of breast, ovarian, pancreatic cancer.
Yes, or male breast cancer in the family, or bilateral breast cancer, yes, or a triple negative breast cancer, which is the diagnosed before age of 60, or multiple BARCAs in the family. All these things is just coming to you. Yes, you need to evaluate the risks and you need to think about, will I go ahead and do here BARCA or no? With the presentation which I gave to you, if they are not giving you a detailed family history, you don't go ahead directly and refer this patient to genetic testing. You need to check about family history, you need to reassess the risks and so on. And you could just go ahead and refer this lady to mammo. Please search about this question again, study it again, and remember it nicely.
Dr. Abdullah, I remember when I was reading about it, they said if it is confirmed in the, like for example, Ashkenazi Jews, so you can start prophylactic mastectomy with the constriction of the breast if it is available.
If it's
So
a
you can
high,
start it early, like before
yeah,
30.
I think you
And
would more prefer to monitor them. But if you are doing a prophylaxis here too, it could go for it, but you will need to do counseling before it.
yeah, like
So,
bilateral, and also we can go with the oophorectomy also.
yeah, so once you get a question for a BARCA referral, you need to think about bilateral breast cancer, relative with a multiple breast cancers, cancers before age 45, and any other cancers or ovarian cancer, sorry, and affected male breast cancer. That's what you're gonna make you go ahead and do your BARCA. Please remember it. So, Wilson, we said read about Wilson, please. Tex. tics, I need you to remember the management which is here. You start with tics with education, counseling, supportive, yes, and you do the behavioral management or helping here. You need to remember the tics or Tourette's syndrome is coming under the tics, and it's happening at what age? Less than 18. Yes, you might have simple motor vocal tics. They wrote for you about the types here, but you need to remember the management here. The management which is written here, that's what you're gonna go down and use it in your Tourette's. Yes, so Tourette's is very important. We spoke about it. What is the triad with Tourette's which you need to remember?
OCD, tics, and
OCD, ADHD.
and ADHD.
And if you wish to see where it's written to you, where's Tourette's? Yes, Tourette's is here.
Psychiatric compulsive behavior and ADHD.
Yeah, ADHD and OCD. It's mentioned for you here. Did you see it?
Yes.
Very important. So typically, their rating for you begins 4 to 6. It peaks between age 10 to 12. Yes. So is it presenting to you with a good prognosis or there is no good prognosis here?
Sorry, the prognosis is good.
How is the prognosis here?
With the tics?
50% are tick-free at the age of 18.
50%. So what you can do here is you're gonna try to control and educate the family maybe, or maybe help the patient with even the teachers or whatever at the school. Yes, educate people who surrounding about this disorder. Yes, because sometimes it's very hard to control it. Yes, it's a little difficult to control it. So ALS, very important. There is
Sorry, doctor, just one thing I get. They said that tics, if they don't think about it, so it's less. If they more think about it, the anxiety make it worse.
So it comes with many things can aggravate the tics. And
Stress.
sometimes it's very hard to control it. When you try to control it more, they are losing control in it.
Yeah, so that's why they
So
said like just distract, like don't care about it, so then it will be less.
yes, yes. So next question is very important. Please concentrate on the next questions. They are very important. Someone wishing to pass this exam soon, come take it.
Me, doctor.
Okay, doctor. Dr. Stephanie, wake up. We are just starting. So yes, you are seeing a 16-year-old boy with a Duchenne muscular dystrophy who reports increasing disability, including the leg weakness and difficulty walking. On examination, he has scoliosis and diffuse proximal muscle weakness. In addition to multidisciplinary supportive care, what is the best management for this patient? Duchenne musculars, guys, you need to study it nicely. Write it down. You need to know every single word about it.
Yeah.
What is the best next step?
Doc, could you send it in the group, Doc? I got a part of the question. I didn't get everything.
It's a 16-year-old boy, Duchenne muscular dystrophy, who reports increasing disability and including a leg weakness, difficulty walking. On examination, he has scoliosis and diffuse proximal muscle weakness. In addition to multidisciplinary supportive care, which one of the following management approach is the most appropriate in this patient?
In these patients, we need to check for the respiratory
Dr.
function.
Stephanie, what they are asking you about?
Support.
Support, yeah. So
They are not asking you about support. They are telling you, in
Electromyograph.
addition to multidisciplinary supportive care, what is the most following management? They
Yeah.
already did the support.
Yeah.
So,
Some
like
of the
a
management approaches
symptoms
is most
worsening,
important.
we have to
What you gonna give?
Steroids?
Steroid. Thank you so much.
Steroids.
Steroid was the answer.
I thought that.
So, yes, Dr. Karan.
No.
Yes.
It's okay then.
A 51-year-old woman comes to your clinic with a progressively worsening lower back pain that radiates down her right leg to the lateral side of her foot. She reports no trauma, no urinary incontinence, no fever, and MRI or the MRI of the lumbar supine shows disc degeneration and herniation. So there is a herniation which is compressing S1 nerve root. Which of the following is the most likely finding in the physical examination?
Oh, that sciatica, when we do the sciatica test, I think it's the physical finding, like when we do the examination.
51-year-old woman comes to your clinic with a progressively worsening lower back pain that radiates down her right leg to the lateral side of the foot. She reports no trauma, urinary incontinence, or fever. MRI of the lumbar spine shows a disc degeneration and herniation, which is compressing the S1 nerve root. Which one of the following is the most likely finding on the physical examination?
Foot drop.
Why, Dr. Koran?
To fight.
I think S1 is responsible for the
S1 nerve root, it
plantar
controls the plantar flexion.
Yeah, plantar flexion.
So they need you to remember weak Achilles tendon reflex.
Oh.
Yes, because a weakness in the muscles there is going to lead to a diminished Achilles tendon reflex, which is going to cause for you impaired toe walking.
Right.
Because the S1 nerve route, it controls the plantar flexion through which muscle? Soleus musculus,
and
muscle,
the gastrocnemius.
and the
Gastrocnemius.
gastrocnemius, yes, and the soleus muscles. So when you have a weakness in both muscles, it's gonna affect for you the Achilles. You need to keep this information in your head. Next question, very, very high yield and important. Someone new, come try to take it. Come on, guys, so we can finish for today.
I can try.
A 32-year-old woman with advanced ALS has written advanced directive, stating that she does not want resuscitation in the event of respiratory failure. She presents to the emergency department in respiratory failure, and her family insists that you intubate her to save her life. What is the most appropriate next step?
Intubator. So if she, like that's her wish, so we have to follow the patient's wish.
But the families, they want to intubate her.
But we have to check if this is a recent, like.
You have no more information in the question, Dr. Sajd. What are you going to do?
Doc, I would inform the family that based on her last her last wishes, she does not want to be resuscitated.
Yeah.
So I would give supportive care, and that's it.
Is intubation in her best interest or not? Before
It's in
discussing anything,
it's in her best interest. What you gonna do, Dr. Andrew?
I'll hold a family meeting and call the ethics board.
So
A physician that prioritizes the safety of the patient is a good physician. I know that advanced directives wins, but first I have to assess the benefits of
but the
intubation.
problem here is it's ALS, Dr. Andrew.
The quality
Okay.
of life.
We need to follow the tax directive.
Okay, in this scenario, it's not in her benefit.
Then there is no benefit. Here we're gonna follow the written advanced directives and provide just a comfort care.
Yeah.
Yes, because ALS is very bad.
Yeah.
Very bad. So a few hours later, the same patient of Dr. Sajda's, the patient's mother tells you that her daughter whispered her earlier that she might want to be resuscitated if she gets disoriented. What is the best next step?
Then is she whispered, right?
Resuscitate. Yeah.
Then maybe we resuscitate, yeah.
Yes, we resuscitate.
If the patient unconscious now, you can go ahead and resuscitate. Yes. So you can go ahead and resuscitate because you're gonna go with the last wish of the patient. Even if she got an advanced directive, if the last thing that she whispered to her mother, you need to go ahead and
resuscitate. Yeah.
Resuscitate. Yes. So
But if the reverse is the case,
what is the case, Dr. Henry?
okay, where the relatives or maybe the wife tells you to not to, and the patient wrote in the paper that he wants to be resuscitated.
Definitely listen to the patient. You forget about that.
Dr. Abdullah.
Or you mean that's the patient, he said that they want to live.
Yeah, they came out and told you that the patient
You're gonna do what is the best
them.
interest here.
Dr. Abdullah.
Yes.
I saw a question where an elderly man comes into the ER. He is confused, right? He's in shock. Not shock, but he's going into shock and he's confused. And you need to take him to surgery, but he says he refuses surgery. His daughter is there and says, take him to surgery, but he refuses. In a situation like that, I believe the answer was hold a family meeting to find out, to decipher what the patient would have wanted when he was capable. That I saw a question like that. I just wanted to share with everybody.
If the patient, if he's incapable in this condition, you will look for the next things, either SDM or you're gonna look
He didn't have
for
an SDM.
yes, if you don't have or advanced directive definitely or whatever it is, holding a family meeting here could be an option for you. But if it's something urgent, definitely you're gonna go with the management. So you're gonna take him to the surgery. But you're saying
Even if he's confused.
if he is confused, this is a problem. Then you would like maybe to assess him. Does he has the capacity or no? Maybe that's the best thing you're gonna do here. Maybe he looks confused, but he has a capacity. Yes, you won't know till you assess him. Yes, because he didn't lose conscious yet to just listen to the family yet. Maybe if he's unconscious, maybe you could go and do that. But usually they are just having trouble here because all these things, guys, it's a gray area. Yes, even the point which we spoke about that you did listen to your or someone did listen to colleague. The answer which you were picking, it's not supposed to be wrong. The answer A, which you were speaking about. It's not like, oh, you are 100% wrong. No, it's not like you're 100% wrong. But it's more that, okay, if you think about it, um, if you think that the patient in risk, life in risk, if you think that there is something unfair or something here is happening wrong, here you could go and escalate it and report. If you think that, okay, there is no one at risk, everything sounds good, yes, and it was just a talk, maybe you can go and speak with this surgeon. Yes, before anything happen. If he refuses, definitely go ahead and report. So it's not always like it's black or white. They love to play with the gray. Yes, and that's the problem of this exam. You need to more read. You need to put yourself more on the situation. So if the question was about a patient who is confused, you would love to go ahead and assess this patient. Can he make a decision or no? Does this patient get a capacity or no? So yeah, you go with the last wishes. You are seeing a 62-year-old woman who brought to your clinic because of a 6 month of progressive weakness in her arm and legs. She also reports a difficulty swallowing and holding her head up during this period. On examination, is pooling of oral secretions, muscle strength and tone are decreased in the upper extremities. Deep tendon reflexes are 4 plus in the left lower extremity. Sensation to light touch and pin prick and vibration so are intact. So what is the diagnosis here?
It's ALS.
That's
Yeah,
ALS.
ALS.
They are describing it to you. So idiopathic, it's the most common here. Segmental, they are writing for you here. Let me show it to you. Yeah, upper motor neuron and lower motor neuron symptoms. So you're gonna find both of them. They're gonna find, or you're gonna find sparing of sensation, and ocular muscles, bowel, bladder, sphincter as well too. So please remember all of them. They wrote for you here about muscle atrophy, hyperreflexia, bulbar findings, and they wrote for you bulbar in each one. It's a flaccid. You're gonna find they may have a nasal quality as well too. Yes. So just go through the symptoms.
Doctor,
What is the treatment?
sorry, this one,
What is the treatment?
maybe prednisone
Riluzole.
or riluzole. How
It's
we differentiate it from the GBS? Like GBS also have muscle, but it start from the lower limbs, right? GBS.
So how we differentiate GPS and ALS, guys?
GPS
Well,
is
GBS is
ascending
like
weakness. Bilateral ascending weakness. You will have also a high albumin on the tab.
right. So
And
GBS
it's
has
both
ascending
both
weakness, irreflexion,
Campylobacter. What?
autonomic
GPS,
dysfunction.
it's acute. You cannot
Yeah, that's
just mix it with ALS. ALS, it's a chronic progression. GPS is just acute. It's ascending, symmetric weakness. Yes. Here you have a big problem. Here you have an upper and lower. It's more severe than GPS. You cannot just mix them because it's going to be a clear for you. So, what is the treatment for GBS? IVIG or plasmapheresis.
Yeah.
What is the treatment here? Riluzole.
Riluzole.
Yes. So, supportive riluzole. It's gonna just slow the disease progression. What's the side effects of riluzole? They love to ask about it. hepatotoxicity. That's why you're going to go ahead and monitor LFTs, nausea and upper GI symptoms, fatigue and weakness, dizziness, neutropenia, all of them. Please remember about the side effects of riluzole. If the patient is presenting with ALS and there is a nocturnal hypoventilation, what are you going to do?
CPAP.
You're going to go for the
Or
non-invasive ventilation.
yeah, NIV.
Yeah, non-invasive ventilation. So yeah, I think that we are almost done for today. GPS, we repeat it every session. I don't think that we need to repeat it anymore. We keep repeating GPS each single session. So I think that you know that it's important. Myasthenia gravis, they love to ask about what is the most common association. You know them, the three, I keep repeating it for you. Thymic hyperplasia, thymoma, or autoimmune thyroiditis. Yes, they're gonna give you a fatigue, eye charge, or eye changes, sorry, weakness towards the end of the day. They love to mention for you these words. You need to remember it. The most important point they love to ask about it is decremental. Because if you go ahead and you find it incremental, what are you gonna think about?
Sorry,
Lambert
lumbar
Eaton.
return, lumbar return.
Lumbar Eaton, yes. And lumbar Eaton is mentioned for you here. What is the treatment for myasthenia gravis?
Steroids.
Pyristigmine before steroids.
Pyristigmine.
Pyristigmine, Dr. Sajda, it's written for you here. First
Yes,
line treatment.
yeah.
So lumbar Eaton, very important as well too. Yes, it's only motor, and it's associated with what? You need to remember it. It's associated with a small lung carcinoma. Yes. So they give you the presentation, they give you a combination of smoking history, chronic cough, and weight loss is happening. So you're gonna think about maybe a concern for a lung malignancy, but look for the muscles. Do you have a proximal muscle weakness or no? So if you have a long or a proximal muscle weakness, what are you gonna think about?
Number 8.
PMM, a PM. No.
This is what they love to
Dermatomyositis.
confuse you between them. Lumbar Eaton, they are telling you reflexes diminished or absent. They are telling you a weakness of a skeletal muscle without sensory coordination. When they give you a presentation of a smoking history, chronic cough, and weight loss concerning for a lung malignancy, and the proximal muscles, which is improving on repeated stimulating combined with hyporeflexia, it's suggesting for you the
Lambert Eaton.
yes, but they call it the paraneoplastic syndrome. Did you hear about the paraneoplastic syndrome, which is associated with the lung cancer?
Yes, I think we have also calcium high, glucose high.
With you, doctor, when we studied that, was lung cancer, like SIADH and neuroendocrine syndromes, ACTH secretion as well, ectopic ACTH.
So
Sorry, I have one quick question. Do the patient with GBS, do they recover completely after treatment or they stay like that?
the GBS?
Yeah.
I think GBS because it's just I think that they have still a chances for a mortality as well too. But I think that the symptoms is gonna be resolved just with the treatment. I don't think that they're gonna just be suffering the whole time.
Oh. Okay.
Yeah, they ask about the bacteria with GBS. Which bacteria is gonna be with the GBS?
Clostridium.
Most common
لا
no GBS. Campylobacter. And what is the Miller-Fisher variant of GBS triad?
Or ataxia, ophthalmoplegia, and areflexia.
Yes, very nice. So, and you need to differentiate between the paraneoplastic syndrome and with the lung cancer and the Lambert-Eaton. So Lambert-Eaton, it's one of the paraneoplastic syndrome. Paraneoplastic syndrome, it's the big category. Lambert-Eaton, it is the specific one. So they can give you the presentation, which I told you about it. It's a smoker. He's coming to you. He's having or presenting with a weight loss, and you're thinking about lung malignancy. You have a proximal muscle weakness improves with a repeated stimulation combined with a hyporeflexia, which is suggesting for you, if you don't find Lambert-Eaton, go for the bigger group. And you're going to find the answer for you. It's a paraneoplastic syndrome associated with lung cancer. Lambert-Eaton is one of them. If you don't know that it's one of them, you won't be able to answer this question. And EMG, as we said, it's going to be incremental. If you find your EMG as decremental, it is?
Myasthenia gravis.
Myasthenia gravis. Yes. So they are telling you here tumor removal. Yes. Did you get the point, guys, about the paraneoplastic syndrome?
Yes.
So it's just a bigger
No,
picture.
no, Dr. Abdallah didn't get that
It can
one,
also
please.
be dermatomyositis, right? As part of the paraneoplastic syndrome.
Paraneoplastic syndrome, it's the big umbrella.
Yes.
It can under it so many things. Yes.
Sure,
It could be
sure.
your Lambert-Eaton. It could be SIADH. It could be ectopic ACTH, which you are thinking about Cushing maybe. So small lung cancer. If you have a squamous cell cancer, guys, lung cancer, what are you going to think about?
SIDH.
Squamous.
Hyponatremia.
Hypercalcemia.
Yeah.
Hypercalcemia. Why hypercalcemia is happening with the squamous cell lung cancer?
Because it secretes a parathyroid hormone-like protein.
Because it's parathyroid hormone related
PTHRP.
tumor-like syndrome.
So if you have a lung cancer, weakness, and areflexia and dry mouth, what are you going to think about?
Lumps,
Repeat that, Doc.
Lumps, no?
Lung cancer, weakness, and areflexia, dry mouth. What are you going to think about?
Lambert-Eaton.
Lambert-Eaton. Yes, yes. You're going to think about Lambert-Eaton. And which cancer you're going to think about?
Small
Lung
cell.
cancer. Yeah, small cell lung cancer.
Small cell.
Yes, yes. And you remember the incremental and decremental? Botulism.
Sorry, which is incremental? Which is decremental? Okay, okay.
Did you see it?
Just...
Did you see it where it is in the book?
Okay, yes, I've seen it. Thank you.
My appreciation to your gray matter. Botulism, you know about it. Honey or the corn syrup in kids, yes? What else we can get botulism from it?
Wounding adults.
You need to study
Wound
botulism very
botulism.
nicely.
I think
food.
heroin users as well, or injury from
Wound
cans.
botulism, then cans.
Okay. Canned food, maybe.
Yeah.
Okay. What is the most common bacteria associated with GBS?
Campylobacter
Campylobacter.
Campylobacter jejuni.
Proudly Canadian.
At least someone. Yes. And Clostridium botulinum here. What is the treatment for botulism?
Antitoxin.
Antitoxin.
Botulinum
Immunoglobulin.
antitoxin. Yeah, supportive. So supportive therapy,
Antitoxin
yes,
3.
as required. So you need to monitor the respiratory status. So assess the need for intubation for sure, but botulinum antitoxin is gonna be giving you a good prognosis here. So yeah, I think that we studied which is here, neuropathic pain and trigeminal neuralgia. We spoke about it earlier, yes. You need to know the difference between them and how you're gonna treat them. I think we have done them as well too. And it was supposed to be your homework. Hopefully you did study it. So Ramsey Hunt, Bell's palsy, and trigeminal or post-herpetic neuralgia. So you need to differentiate between them. I think it's enough for today.